Hello everyone, my name is Marsimon. I'm the Director of Arrhythmia Services at AAG Hospitals, Hyderabad. On behalf of the organizing team, Dr. Ajay Behel, Dr. Balaji from the US, Dr. Hesham, and Dr. Praveen Verma from Cochin, and Dr. Muttaya, who is my colleague, I would like to extend a very warm welcome to everyone gathered on this platform virtually. These are very difficult times over the last year or so. There's been a major pandemic, and it has really affected the way we practice medicine, we conduct our CMEs, so on and so forth. Despite these difficult times, I'm glad that some of us are able to get together on this virtual platform. Thank you all for taking time to join this symposium. We are truly delighted to have an excellent faculty, including some of the pioneers in the field of hypertrophic cardiomyopathy. These people have changed the way we practice taking care of patients with hypertrophic cardiomyopathy. For example, the natural history studies from Dr. Barry Marin or the sudden cardiac Euroscore from Dr. Terry Elliott really paved the way to better re-stratify these patients and take care of them in a better way. I'm really grateful for each and every one of them, for all the faculty and the chairpersons who have taken time from their work and from their families. For all delegates, you will find this meeting extremely relevant, informative, and it will help you to take care of your patients better. I'm sure it will improve our knowledge regarding hypertrophic cardiomyopathy, bringing us up to date in terms of the contemporary practice of taking care of patients with hypertrophic cardiomyopathy, and it will significantly improve the standard of care in this part of the globe. The chairpersons are all eminent physicians who have been involved in taking care of patients with hypertrophic cardiomyopathy. Where you can direct all your questions from the delegates to their chat boxes. The chairpersons will go through the questions and direct them to the appropriate speakers, and we'll try to get all the questions clarified or answered during the session itself. We will try and address most of your queries, but in case for want of time it exceeds, please feel free to post them. We'll try to address them later on in your email or in chat boxes later on. Once again, thank you all for joining this symposium. Please stay safe. I will hand over the mic to Muttaya to introduce the chairpersons and welcome the chairpersons for the first sessions. Thank you very much. Chaired by an eminent panel. One second. One second. Now,
Sorry. So the first session one will be chaired by an eminent panel. I hope everyone will hear me. Dr. Vijay Chopra from New Delhi, Dr. Krishnan Raju from Hyderabad, India, Dr. Ram Prasad from Bangalore, India, and Dr. Dr. Tangaraj from CCMD in Hyderabad, India. So now we'll have some. Most of the recordings will be pre-recorded. So we'll have an introduction by the chairperson of the speaker, followed by the recording. And after the completion of these four topics, we'll have a common Q&A session where the chairpersons and faculty will be available. So I'll hand it over to Dr. Krishnan Raju, sir, so he can introduce our first speaker.
And thank you very much. Good evening to all of you. It's going to be a very important and very dynamic session of a problem which all of us have been seeing quite frequently. So, do I have Professor Ramakrishna? Professor Ramakrishna?
It's recorded also. We will play it.
Okay. So the first one will be by Professor Ramakrishna, Professor of Cardiology, and Institute of Medical Sciences, New Delhi, India. So Professor Ramakrishna will be speaking on making the diagnosis of hypertrophic cardiomyopathy, recognizing the hypertrophic cardiomyopathy phenotypes. So we'll start with, this is going to be the first lecture. Professor Ramakrishna. Is somebody playing it?
Greetings from India. I think this is one fantastic symposium where we have almost galaxy of stars from across the globe who are the world's leading experts in HCM participating. And it's a privilege to be standing in front of you, giving you the first initial talk. I'll be giving a prelude to what is going to come in the whole day, 2-day exercise. I think we are passing through a phase of time. COVID, unprecedented, never had something like this in our lifetime. But good about COVID, and one such thing is this seminar. Possibly without this COVID situation, this seminar would not have happened in primary place, and there is something good about such a bad thing. So my topic is making a diagnosis of HCM and how do you recognize the HCM phenotype. So HCM, we all know this is most common monogenic heritable cardiomyopathy, which is a prevalence of 1 in 5,000 people. The sarcomeric protein gene mutation are seen in 60% of cases, and marked genetic and phenotypic heterogeneity is very much characteristic of this disease. How do we define HCM? So HCM is hypertrophy. So the way in which the hypertrophy is defined in adults is a wall thickness of 15 millimeter or more in LV myocardial segment as measured by any imaging technique is the standard definition. And that should not be explained by some loading conditions, like for example, hypertensive LVH or aortic stenosis producing that LVH. In children, because of their size, we use the Z-scores, that is LV wall thickness are greater than 2 standard deviation from the predicted mean. So a greater than Z-score of greater than 2 is considered diagnostic of hypertrophy, defining HCM in the absence of any etiology of LVH. So which imaging technique should be used? So we can the most commonly used is transthoracic echocardiography. I think that remains the most common and widely used imaging modality, especially in patients suspected to have HCM. Transesophageal echocardiography is quite useful in assisting the procedures in specific situations where you want to assess the etiology of MR, or in situations where transthoracic echocardiography windows are very poor. Cardiac magnetic resonance has revolutionized the almost all cardiomyopathy imaging, and this is true for HCM also. I think it has brought in new facets of disease that we never realized before. And computerized tomography also could play a role, especially in assessing the etiology of HCM or in diagnosing the LV mass and other things. So, mind you, imaging can never be a replacement for an astute physician. Imaging can only assist you. This is an example, a 60-year-old female we encountered in our practice, like hypertensive female. She has been having a 6-month duration of class 2 dyspnea and exertion and angina exertion, and she has been extensively evaluated outside some private hospitals. She had concentric LVH on echo with 13 millimeters the wall thickness. She had left atrial enlargement, diastolic dysfunction. The coronaries were also done, which showed 40 to 50% proximal LAD disease. And she was managed as hypertensive heart disease with insignificant CAD. But since her symptoms did not improve, she consulted us, and some of the other hospitals have advised FFR for that proximal LAD disease for evaluation. Upon investigation and interrogation with the patients, she threw a history that her elderly sister who resides in US was diagnosed to have some 20 years back, diagnosed to have some heart muscle disease. So we asked her to bring all the papers records, and to our surprise, that was actually proven to be a hypertrophic cardiomyopathy with some sarcomatic protein mutation in her sister. So we repeated the gene analysis here also, and she turned out to be a classical HCM with a major gene mutation like. So I think now she has been under for a follow-up, managed medically managed for restrictive physiology as well as HCM, and she is doing well for now almost 7 years in follow-up. So what do we do if the LVH is borderline? So this classical case of mine that I showed is classically tells you that in the presence of a family history, the diagnostic a patient relative is diagnosed with established HCM, even a 13 millimeter is good enough to make a diagnosis of HCM. There is non-cardiac symptoms and signs have to be evaluated in such patients that there has lesser degree of wall thickening. ECG abnormalities, other laboratory tests, and multimodality cardiac imaging may be needed to establish HCM in these patients with borderline LVH. So coming to my primary topic, it's what is typical HCM phenotype? This phenotype is one, abnormal hypertrophy, often which can be just focal, that may result in various improvement of cardiac function, including diastolic dysfunction, outflow tract obstruction, mitral regurgitation, atrial and ventricular arrhythmias, pulmonary hypertension, and coronary insufficiency and congestive heart failure. So I think somehow diastolic dysfunction is now being recognized as a very important component compared to outflow tract obstruction, which was our major focus for ages now in HCM. So what about the hypertrophy in HCM? Hypertrophy in HCM is asymmetric, involving predominantly the septum and the anterior wall in 70% of patients. It can be just the basal septal hypertrophy in 15% to 20%. It can be concentric elevation in 8 to 10%. It can be apical or lateral, which is around 1 to 2% across the world, but it can be very high in Japan. Then you have the location is, as I told you before, like it's a confluence of basal septum where most of the patients are having it, and the next common site is posterior septum at the mid-LV level. The extent of hypertrophy can be classified as focal, intermediate, or diffuse. The focal means less than 3 segments are involved, intermediate means 3 to 7 segments are involved, and most common diffuse means greater than 7 segments are involved. RV hypertrophy, if it is found, is almost mostly limited to the septum which is adjacent to the anteroseptum, where most of the LVH happens in the LV side. But in half of the adults, it can be diffuse RV hypertrophy from MRI imaging. Like the other common site of obstruction is the mid-cavity obstruction, where I think it's the predominantly the hypertrophy happening at the mid-ventricular level. These patients, if there is obstruction is there, the obstruction is mostly at the level of the papillary muscles, and this obstruction over long term can lead to thin and dyskinetic apical pouch with resultant arrhythmia, embolic complications, and so on. Generally, in these patients, there is no mitral SAP. Apical HCM is 1 to 2% of all HCM. The LV apical thickness is greater than 15 millimeter, and the ratio of maximal apical to posterior wall thickness is greater than 1.5. The apical HCM is pretty easy to diagnose on ECG because most of the time it has a characteristic ECG with T waves which are characteristic, depressed, very tall T waves, and has a spade-like configuration of LV is characteristic. The apical HCM can be of two types. One is non-massive apical HCM and the massive apical HCM, which is the Japanese phenotype. So the non-massive apical HCM, the end diastolic thickness is less than 30 millimeter. It may be in combination with other LV segments, and it is generally has a very favorable outlook, a very low risk for developing obstruction or apical aneurysm, and these patients are usually asymptomatic. Whereas massive apical HCM, which is commonly found in Japan, has systolic cavity obligation and apical aneurysm formations are pretty common. So, as I told you, like there is so much of heterogeneity about phenotype of HCM also. I think the classification is also quite heterogeneous. Initial classifications were like mostly obstructive type and non-obstructive type and focused on where exactly the hypertrophy was located. Then subaortic obstruction, mid-cavity obstruction, and cavity obliteration are the other classifications. And then there was a suggestion that we should classify the HCM mostly genetically but not morphologically. But then morphological classification has been proposed by the ESC group. And we can look at some of the various classifications. So this was the initial classification proposed by Maron. This focused on where exactly the hypertrophy is located. I think further classification by Syed et al. Has classified HCM into reverse curvature septum or sigmoid septum depending on the curvature it takes and the shape of the LV cavity. So in the reverse curvature septum HCM, you have a predominant mid-septal convexity towards LV. And there is a cavity which is crescent shaped, and there is a generally a dynamic LVOTO, usually with SAM of the metal leaflet. This is the common carbon variety that we commonly encounter. In the sigmoid segment HCM, the ovoid LV cavity septum being concave to the LV cavity, and the predominant basal septal bulge will be there, and there is subaortic obstruction and SAM, and there is a posteriorly directed jet of MR is characteristic of this type. And there is a neutral type of septum HCM, where generally the septum is straight, and there is neither predominantly convex or convex towards LV cavity. Subaortic obstruction is usually less frequent. Then you have the apical HCM and the mid-ventricular HCM, which we discussed before. And then in some patients, there can be just asymmetric posterior wall hypertrophy that can be just found. So these are the various different types that we find. Sigmoidal HCM is found in 40 to 50%, reverse curve is in 30 to 40%, apical HCM is in 10%, neutral is in 10%, and the age groups are slightly different. And the genetically, most often reverse curve HCM, you find the genetic mutations are more commonly found. So histological phenotypes are also heterogeneous. We understand that asymmetrical septal hypertrophy, as well as myocyte disarray and the microvascular abnormalities, the characteristic triads of HCM. But there is so much heterogeneity in terms of number of fibroses, the amount of disarray, and the disarchitecture that can be there. It is, I think, possibly a hypertrophic cardiomyopathy can be very easily termed as hypertrophic heterogeneous cardiomyopathy. The other characteristics of HCM phenotype which are very common are mitral valve abnormalities, which were initially not considered as very important, but we all recognize it is more common than what we considered initially. But now it is considered as a phenotypic expression of HCM. That can be elongation of mitral valve leaflets, hypertrophy of papillary muscle heads, increased number of papillary muscles, anterior apical displacement of the papillary muscle, and there can be direct insertion of anterior papillary muscle into the ventricular aspects, and there can be accessory muscle bundles, mitral valve collapse, mitral annular calcification, and then anterior leaflet fibrosis where there is a septal leaflet contact is there. So these are the various papillary muscle anatomy that can be found. You can have, there can be elongated hypertrophic papillary muscle, there can be apical displacement of the papillary muscle, there can be hypertrophy of the papillary muscle producing mid-cavity obstruction, or can there be abnormal attachment of the papillary muscle into the anterior leaflet, or there can be abnormally elongated anterior papillary, anterior mitral leaflet. So what causes LVOTO? So LVOTO is caused by various morphoanatomical factors like narrow LVOT, elongated mitral leaflet, which is now being after most of the MRI studies that is now considered to be one of the most important feature that produces LVOTO. And there is anterior displacement of the AML and the coarctation at body, and then venturial drag and funnel-shaped MR can result from it. So we now know that the LVOT phenotype has relatively poorer outcomes and more chance of symptoms and outcomes related to HCM. Coming to asymptomatic septal hypertrophy, most patients with HCM have it, but now we realize that it is no longer necessary or no longer sufficient to diagnose HCM. Septal to posterior diastolic wall thickness ratio of greater than 1.3 is the classical cutoff, but in hypertensive patients, especially with inferior oral MI where there can be posterior wall thinning, the ratio is considered to be 1.5, greater than 1.5 to diagnose asymmetrical septal hypertrophy. But it can be false positive when you overestimate the septal thickness because of moderator band or an LV tendon, or because of sigmoidal septum in an elderly patient. The another one that is initially thought to be diagnostic, which no longer requires for the diagnosis, required for a diagnosis of HCM, is systolic anterior motion of AML. It is found in 30 to 60% of HCM, but 25 to 50% of them actually have LVOTO. It can be found in multiple other conditions like other cause of hypertrophy, hyperdynamic states, and hypovolemia. It actually prolongs ejection time, reduction in the stroke volume, and it produces MR. Whether it is primarily because of a Venturi kind of an effect or whether it is because of a primary abnormality of an AML, we don't know. So what does various phenotypes tell you? There are some very important information that all these phenotypes tell you that if there is an asymmetrical septal hypertrophy, especially if there is systolic anterior motion of metal leaflet, LVOTO development is very high chances are there. And the presence of LVOTO, it increases the risk of evolution into end-stage heart failure, and they are likely to be more symptomatic. And there could be more conduction delay and suspicion that there could be more SCD. And massive hypertrophy is clearly an indicator of sudden cardiac death. And mid-cavity obstructive HCM, more development of LV apical aneurysms and all the complications related to apical aneurysm. The non-massive apical forms have a pretty good prognosis. Coming to the other important phenotypic aspects that we should consider is what about the LV function in HCM? LV systolic function is normal to supernormal. And in late disease, because of myocardial fibrosis, there could be fibrous transformation from loose intracellular connective tissue. There is myocardial ischemia and infarction of small vessel disease, and LV dilatation and dysfunction. You can end up having end-stage HCM. But diastolic dysfunction is more often recognized now as an important cause of heart failure and an important contribution to symptomatology of HCM. Impaired relaxation is a more important contributor to diastolic dysfunction in HCM than LV compliance per se. And there's various pathways that are involved in producing relaxation abnormalities. So what are the stages in this phenotypic progression of HCM? So initially we have a subclinical HCM, then we have the classical HCM phenotype that I have described so long. It is 75% of all these patients. And then you have adverse remodeling and over dysfunction starts in 15 to 20% of patients, and then end-stage HCM is 5 to 10% of patients that present to us. So what are the common heart failure profiles in HCM? You have LVOT obstruction, end-stage LV systolic dysfunctions are well-recognized causes, and something like a restrictive physiology, like almost presenting like heart failure with preserved ejection fraction, is more increasingly recognized. In this large series, where 300 patients are followed, 50 developed severe progressive heart failure, out of which 30% were due to end-stage systolic dysfunction. LVOT at rest was contributing to only 22%, whereas non-obstructive with preserved systolic function contributed to nearly half of patients who develop severe progressive heart failure. AF is an important contributor in a majority of these patients, and patients who present like preserved ejection fraction heart failure like symptoms, they have earlier onset of heart failure symptoms and most accelerated progression to advanced heart failure, and they have adverse outcomes. And the extensive myocardial scarring is actually contributing to almost all these three classes. With increased advanced imaging, we now have a lot of milder forms of HCM like mild hypertrophy with only abnormal myocardial strain, systolic anterior motion or elongation and only the morphological features. Or on MRI, we can find the myocardial crypts, you have trabeculations, and you have de Villiers LVH, which is not fully appreciated by echocardiogram, and you have only aortic gadolinium enhancement with just the future. Can we label these as phenotypes of HCM? Or what is the long-term prognosis? Is it absolutely benign? We really don't know. These are the various group of patients that actually develop HCM with the sarcomeric protein mutations contributing to 40 to 60%, and other genetic and non-genetic causes contributing to around 5 to 10%, and almost 1/3 of patients we don't know the cause of HCM. But what are the determinants of phenotype in HCM? Actually, there is a big interplay of genes, the various other modifications of genes, and the environmental factors contribute to the various phenotypes that I have described in HCM. So, how are we doing in terms of HCM diagnosis? We commonly pick up HCM when patients come with classical symptoms of angina, syncope, or dyspnea, or sometimes the patient presents with aortic sudden cardiac death or various arrhythmias, or very rarely we pick up nowadays with auscultation, abnormal findings on auscultation or abnormal ECG. And often we now find with, especially after increased family screening, we find a lot of patients with genetic screening, positive family member, and then they are screened and diagnosed to HCM. And quite a few are being incidental traumas found on imaging studies. The ECG in HCM is a good screening tool. It is abnormal in a vast majority of patients. 75 to 95% of HCM have LVH, and then LAHB and LVBB is found in 25% of patients. Apical forms have high voltage and negative T waves. Obstruction form have pseudo-infarct pattern. Echocardiography described the various phenotypic abnormalities that I have described can be picked up by echocardiogram. And now with echocardiography is also emerging, there is strain rate imaging for diagnosis, prognosis, and phenotypic classification, which should be dealt by subsequent speakers. There is a good amount of improvement in the way we understand astrology with echocardiography. Stereocardiography, 3D echocardiography, contrast echocardiography all could have a role. And twist imaging also is important in echocardiography. And whatever echocardiography can provide in terms of morphology, CMR seems to do better, and especially CMR now can find a lot of information about the functional aspects of HCM also. But despite all this imaging, there's a big problem, there is a big diagnostic challenge in HCM because not every patient has hypertrophy, not every patient has LVOT obstruction. There is a group of patients, a large chunk of patients which are both, where the diagnosis is pretty simple and obvious. There is a group of patients who have only hypertrophy or only LVOT obstruction where the diagnosis can become tricky. This is one example, like a 40-year-old with suspected ACS. He, upon evaluation, initially suspected HCM, but later on it turned out to be myocarditis, and with echo and follow-up, the whole hypertrophy disappeared. So there can be various other mimics of HCM, like in this patient who presented with 58-year-old with new onset breathlessness, like HCM-like picture with hypertrophy with mild MR, later on turned out to be lymphomatous infiltration of the myocardium due to non-Hodgkin's lymphoma. There can be various mimics of HCM phenotype. The most important thing that we are looking at is the LV septal thickness. If it is greater than 15, and if there is dynamic LVOT obstruction, there are very little causes like except for hypertrophic obstructive cardiomyopathy, with a significant exception being hypertensive disease of the elderly with a sigmoid septum. Sometimes there is no obstruction, and there can be non-obstructive hypertrophic cardiomyopathy or hypertensive heart disease. If there is a dynamic LVOT obstruction is absent and the LV septal thickness is borderline, this can be early hypertrophic obstructive cardiomyopathy, or there can be athlete heart, which is, I think, a separate topic, how to differentiate athlete heart from HOCM. How are we doing? How are we diagnosing HOCM? Even before the corona mask is known, I think HCM is seen to be wearing a mask. 90% go unidentified, and unfortunately, it remains one of the causes where I think first time it is diagnosed when somebody dies. And it's one of the most common causes of sudden death in athletes, and even in non-athletes, it's a very important contributor to sudden death. I think some of these patients give us an opportunity to diagnose. Like for this example, in this patient who is 16-year-old who died of HCM, had a history of syncope, and many have such a history and provide us an opportunity to diagnose. The onus is on us to diagnose HCM because nowadays with imaging modalities, once you do an imaging, very hardly you will miss a diagnosis of HCM. But the onus is on us to diagnose early HCM because nowadays it is no longer considered to be a dreaded disease. Now it can be cured and have a very good longevity. So in summary, hypertrophy, diagnosis of hypertrophy remains the cornerstone for diagnosis of HCM, and the dynamic LVOT obstruction is definition of greater than 30, but there are very many challenges as I enumerated in my talk. Thank you for patient listening.
Sir, Dr. Chopra?
Senior lecturer in the University College, London and Queen in the University of London. Over to you, Dr. Secretary.
Thank you very much for this kind introduction. I'd like to start by thanking the organizers for giving me the opportunity to present in front of you today. I'm not an echo specialist, and this is not an echo talk. What I'd like to do is to impress upon you the role of echo in the area of advanced imaging in contemporary practice when assessing patients with hypertrophic cardiomyopathy. To put this into context, it is important when assessing a patient with HCM to make or confirm diagnosis, as has been very nicely shown by the previous speaker, to manage patient symptoms, to determine the prognosis, and last but not the least, to identify those individuals who might be at risk, i.e. first-degree relatives. Echo plays an important role at every key step. So what we want to know is about wall thickness. We want to know about the function. We want to assess the mitral valve, the absence of presence of obstruction, the left atrial size, and last but not the least, the diastolic function. So with this in background, throughout this talk, I'm going to focus on what echo can do. So first, what we want from echo, what it can provide, and where possible, how does it compare with other existing imaging modalities? So let's take this in turn. Wall thickness. This is important not only for diagnosis, as has been shown, it's important to plan intervention and also to assess patients' risk. We're all familiar with this risk stratification, and it's important to note that no longer does the conventional risk assessment just rely on binary measurements of wall thickness. Instead, it's a continuous variable, as is shown in this slide. We've also been shown that when we measure wall thickness, which is in M diastole, and if you have it more than 15 mm in any myocardial segment, that raises the suspicion of hypertrophic cardiomyopathy. The apical HCM, however, falls out of this diagnostic criteria, and one particular thing that needs to be considered when measuring wall thickness is how you measure. As shown in this cartoon, care must be taken to exclude the paraseptal structures, i.e. the papillary muscles and the other trabeculations. This slide is again to highlight that fact. The arrows and the red circles outline the structures which should be excluded when measuring wall thickness during the echo study. So just to show you a few phenotypes, bundle and asymmetrical wall thickness in the anteroseptum and anterior wall. This is a case of apical hypertrophic cardiomyopathy. We can see clear thickness at the apex with cavity obliteration during systole. Moving on to relatives, we start with ECG. And of course, if this is abnormal, this raises your probability. However, a normal ECG does not exclude the possibility of inheriting hypertrophic cardiomyopathy. The threshold of wall thickness is reduced to about 13 mm in one or more segments. And if you see other features on echocardiogram, such as strain or incomplete SAM or elongated mitral valve leaflet or a crypt, as you can see, anomalous papillary muscle insertions, those again enhance or increase your suspicion. It's important that all myocardial segments are assessed in a structured manner. It can be challenging when the hypertrophy is confined to one or two segments, particularly in sites not particularly reached by echocardiogram alone. And those are the times that you might wish to consider other imaging modalities such as cardiac MRI or use of contrast. There is no doubt that echo is the most important modality for making the initial diagnosis of patients with hypertrophic cardiomyopathy. It's inexpensive, it's readily available, there is greater technique, and lots of people who know the skill. And its killer applications include an excellent temporary resolution and the ability to use Doppler to perform real-time and provocative measures during the examination. Of course, CMR has again revolutionized our thinking of lots of heart muscle disease conditions, and its killer applications include tissue characterization. I'm not going to spend too much time on this because later talks have been planned to talk a bit more of this in detail. As shown previously, if there is one term that can be synonymous with hypertrophic cardiomyopathy, it's heterogeneity. These are a collection of patients from our series, and you can see that one size does not fit all. The bottom three conditions or variations can be difficult if you do not have suboptimal echo windows. CMR is particularly good for apex. This is a patient with ECG showing deep T-wave inversions and LVH. The echocardiogram's not particularly helpful. The CMR, however, does show clear evidence of hypertrophic cardiomyopathy, apical variant with complete cavity obliteration. This is another example. The echocardiogram reported mild LVH. However, the CMR shows that the LV wall thickness was about 20 mm. This can be important when assessing risk and when planning intervention for this patient. Let me take you through this case example. This is an 18-year-old boy who was referred to us following a syncopal episode whilst he was playing with his dog in the garden. There is family history of sudden cardiac death. His elder brother died whilst playing football. This patient had been screened about 5 years ago with a normal ECG and an echocardiogram, and it was this recent event which led to another episode for screening. This echocardiogram was reported as normal, as was the ECG. But when we did the CMR scan, as you can see, there is evidence of asymmetrical septal hypertrophy, and aided by the tissue characterization, we can see presence of non-ischemic scar as shown by these red arrows, and we went on to make a diagnosis of hypertrophic cardiomyopathy. The variables added to the ESC-SCD risk score was 6, suggesting possible indication for a defibrillator. The patient was counseled appropriately and the device was implanted. So to summarize this bit, you can see that echo is unlikely to miss obvious hypertrophy, but subtle versions can be missed and CMR can be a useful adjunct. In this study of gene-positive patients who were found to have normal echocardiogram, at least 10% has subtle phenotypic expressions of disease when assessed by cardiac MRI. So moving on to systolic function and briefly diastolic function in the same slides. We know that in HCM, the ejection fraction can be normal or supranormal. And if ejection fraction is less than 50%, that is considered significantly impaired in the context of HCM, hence alluding to the fact that ejection fraction is probably a poor measure for systolic performance. The longitudinal velocities can be reduced often in these patients despite the normal systolic ejection fraction, and it may often be the first sign of development of disease in family members who've been screened for the same. So here's a case of asymmetric or ASH with caudal SAM. The ejection fraction or the radial function is supranormal, but the end systolic volume is low, and you can see the global longitudinal strain is also significantly impaired. This is a patient with apical HCM and apical aneurysm. As you can see, the radial function is dynamic with complete cavity obliteration during systole, and the GLS is markedly reduced in the apical segments, suggestive of apical aneurysm. So this was further confirmed by another study which showed that once patients start developing LV systolic dysfunction, their risk of sudden cardiac events increases dramatically. So to summarize this bit, ejection fraction is high, normal, or increased in patients with hypertrophic cardiomyopathy. A preserved ejection fraction in HCM is already reduced and indicates entering into the dilated phase, suggesting intervention. And events start to occur with ejection fractions of less than 45 to 50%. So perhaps the most important application of echocardiogram, which is unmatched by any other imaging modality, is assessment of the valve, presence of obstruction, and that can help guide intervention. So it's worth spending a bit more time on this particular aspect. About 70% of patients with hypertrophic cardiomyopathy will have outflow tract obstruction. In about 40% it's there, and in some it could be latent. And we know that this is an important cause of patient symptoms. Based on studies, gradients of more than 50 mm mercury have been considered to be the threshold when we might start to consider interventions, as studies have shown for them to be hemodynamically important. So when a gradient is detected, it is important to systematically work up the patient, looking not only for the site of obstruction and looking for other causes, including subaortic membranes, and looking for mitral valve abnormalities. So this structured pathway of interrogation is extremely important. The outflow tract or gradient also forms an integral part of the risk score. And for this reason, it's not sufficient just to, if you have a high resting gradient, to accept it, but to also go on and perform Valsalva maneuvers to get the maximum gradient, as that would again influence your risk. So when assessing for obstruction, it is important to consider the site. Is it just at one or multi-level? The severity of the obstruction, looking at the duration, when the SAM occurs, and also determine whether it is, even if it's absent at rest, does it come on with exercise and other maneuvers, because we know that in hypertrophic cardiomyopathy, the gradients can be dynamic. Care needs to be taken to understand the Doppler profile, looking at the shape, the timing, and velocity. One needs to consider if this gradient is coming from the outflow tract. Is this mid-cavity? And if the estimation, the gradient has been contaminated by coexisting mitral regurgitation. So let's look at this in a stepwise manner. This is a typical continuous wave Doppler profile of a patient with hypertrophic cardiomyopathy. Here, you can see there is seen a shift from convex to concave to the left as SAM, the systolic anterior mitral valve motion, causes deceleration of blood flow, resulting in a characteristic dagger profile that we all recognize as pathognomic of outflow tract obstruction. I also want to point out the presence of mitral regurgitation and why it is important to bear this in mind, because this can contaminate the size of the gradient that is measured. So this is a profile of mitral regurgitation. You can see this occurring quite early in systole. And then just moving the probe slightly, we can then go on and determine the gradient of the dagger profile of the outflow tract. Echo allows us to interrogate the entire LV cavity and at the point of turbulence then to determine the multi-level sites of obstruction if present. This is a pulse wave at the apex, and you can see the short, rapid empty gradient as the apical cavity obliterates. This is the mid cavity, and as we move out towards the just north of where the turbulence occurs, you can see this characteristic lobster claw appearance where there is again obliteration of the blood flow due to the septal mitral contact and obstruction of outflow tract, and the afterload mismatch that we believe is a cause of this appearance. It's again important to localize the gradients. This is a patient with mid-cavity obstruction, and you can see there is this sharp gradient followed by complete loss of signal in the mid. This is where the systolic cavity causes obliteration, followed by the flow coming in diastole. And when we perform Valsalva, you can see the gradients increase and it lasts almost throughout diastole. This may be one of the reasons why patients with mid-cavity obstruction continue to describe symptoms of chest pain. Again, this is a patient who has got mid-cavity with an apical discrete chamber. You can see the Doppler profile of mitral regurgitation, followed by a short systolic gradient here, and the diastolic gradient here as the apical discrete chamber empties as a result of the blood that has pooled up in the apical aneurysm. Again, I said it's important that we don't forget other causes. This is outflow tract turbulence, which is being caused by the presence of a subaortic membrane, as has been very nicely shown by this TOE study. So let's assess the mitral valve. Various anomalies of mitral valve architecture have been found in patients with hypertrophic cardiomyopathy. This is SAM due to elongated posterior mitral valve leaflet. So what this patient does not need is a myectomy or alcohol septal ablation, but needs to be the mitral valve abnormality is the one that may need to be addressed if we have to obliterate his symptoms. The mitral regurgitation jet is usually posterior due to systolic anterior motion of the mitral valve. And if you start to see patients who have anterior or centrally directed mitral regurgitation, this should prompt investigation for intrinsic mitral valve pathology. As a cautionary note, it's also important to remember that not all posteriorly directed jet of mitral regurgitation is related to SAM. Here, this is due to a flayed leaflet. So how can echo help us with planning intervention? Echo is essential when performing alcohol septal ablation. Here you can see after the injection of the echo contrast, the target area has been opacified, and we've confirmed that this is the optimum target site because you can see there is a reduction in the gradient after performing the alcohol septal ablation. Only echo can help us do this in real time. Echo, in this case TOE, is essential when performing myectomy, significant outflow tract obstruction, and post-myectomy, you can see there is reduction of the outflow tract gradient and a nice short myectomy scar. Echo also helps us optimize the gradients by using pacing, and this is a patient with mid-cavity obstruction. And following echo optimization, we showed a reduction in gradient, and this was maintained about a month after follow-up. Last but not the least, echo has an important role also to tell us about the size of the left atrium, which again is an integral part of the new risk score. And this risk is largely related to the risk of atrial fibrillation and stroke. The LA size is measured in the paraseptal view, and studies have shown good reproducibility if the size increases with the risk of events. So I'd like to conclude my talk here, and I hope I have convinced you that echo retains its prime position in the diagnosis when assessing patients with hypertrophic cardiomyopathy, both in terms of diagnosis, management, and prognosis. Echo complements CMR, and both these modalities are very helpful when assessing patients with hypertrophic cardiomyopathy. Thank you for your attention.
Thank you very much. After hearing couple of talks in terms of clinical diagnosis and diagnosis using echo and CMR, so now it's a time for us to listen genetic diagnostics. To talk about that, we have Dr. Lorenzo Monserrat from University Hospital Coruna, not Corona, Spain. Dr. Lorenzo.
Good morning. I'm Lorenzo Monserrat, cardiologist in La Coruña, Spain, and director of Health in Code. I want to thank the organizer for inviting me to participate in this symposium and to talk about genetics in hypertrophic cardiomyopathy, from diagnosis to prognosis. My conflicts of interest. Hypertrophic cardiomyopathy is a very heterogeneous disease with difficult prognosis and difficult early diagnosis. This heterogeneity of the condition is clearly related to the heterogeneity in its etiology. We have more than 1,000 mutations in sarcomeric genes encoding the main contracting proteins, and these mutations and mutations in these genes are associated not only with hypertrophic cardiomyopathy, but also with dilated, restrictive, non-compaction cardiomyopathies. We have also mutations associated with the disease in zeta-DX proteins with different levels of evidence of these associations. We have mutations in RAS-MAP kinases, Costello, Noonan, and so on. And we have mutations in genes like storage diseases genes, Denon, POMPE, Fabry, Prkg2, mitochondrial diseases, calcium regulation, and other. So we have more than 90 genes now that have been associated with hypertrophic cardiomyopathy. Next generation sequencing technologies allow us the evaluation in parallel of hundreds, thousands, millions of DNA bases, and we can evaluate all those genes. So we are going in a new, different situation. In 2010, we were in the situation of Sanger sequencing, looking for the specific gene and the specific mutations. Now we can go to get all the information about the genes that have been associated or could be associated with the condition. This gives us the opportunity to get incidental findings that are very relevant, the lobsters, but will also give us information and data on variants of uncertain significance and non-pathogenic variants that should not be considered in our evaluation of the patients. It's important that even with next generation sequencing, almost half of the patients with hypertrophic cardiomyopathy, we are till now not able to find a mutation. There may be different reasons. One is that some of these patients do not have the disease, do not have hypertrophic cardiomyopathy. Other is that there may be mutations in genes that we have still not found their association with the condition, the presence of variants in deep intronic regions, and other reasons. Some of them may be polygenic conditions and not really monogenic conditions that we can find with our current approaches. Genetics is relevant and useful. I will show you some examples. This is a female, 79 years old, with severe hypertension. Is this hypertrophic cardiomyopathy? There is subaortic obstruction, septal hypertrophy, and apical hypertrophy. Should we do a familial study? The family didn't come. Should we do genetic testing? It's not really the most eligible patient for genetic testing with this age and hypertension. But in the family, her sister came to our laboratory to do an echo after having a stroke. 80 years old, hypertrophic cardiomyopathy with mid-ventricular obstruction and a paradoxal apical flow. This is the daughter of this woman, and this is the granddaughter. The daughter was normal, but the granddaughter has severe hypertrophic cardiomyopathy with a septum of more than 30 millimeters and also a paradoxal apical flow with mid-ventricular obstruction. So in this family, we have two elderly women with hypertrophy, one with hypertension, the other without hypertension, is consistent with hypertrophic cardiomyopathy. Then we have the daughter of one of them, who is normal, age 45, and then we have 18 years old with severe hypertrophic cardiomyopathy. In all of them, we found a troponin C1 mutation that we consider likely associated with the condition, but is still uncertain at some level, and this mutation could explain part of the phenotype, but not the variability. In this case, we were able, with next-generation sequencing, to find a second variant in PTPN11 in the young girl with the severe phenotype. And this variant was not present in any other of the patients. This variant has been previously associated with Noonan and Leopard syndrome in 6 cases, and with also severe hypertrophy. So here you see, it's very important to find this second mutation, because this mutation explains a lot of the things that may happen in the family. This is another family, a woman, age 49, with hypertrophic cardiomyopathy, maximal wall thickness 25 millimeters, a sister with the disease, no family history of sudden death, and she's got one son, 19 years old, and a daughter, 13 years old, that were considered clinically unaffected. Would you perform genetic study in this woman and in her children? The answer should be yes. The guidelines, these are the guidelines of the European Society of Cardiology for the management of hypertrophic cardiomyopathy, recommend genetic testing in patients with hypertrophic, but it enables cascade screening. And in the children of patients with a definite disease-causing mutation should be considered. So if we are able to find the mutation in the index, then we will screen the children. But in this family, the genetic testing was done a bit later. The 13-year-old girl came asking for it after the sudden death of her brother, which was considered clinically normal, and the sudden death of the mother 3 months later on Christmas Day. This is the autopsy of the male with biventricular hypertrophy and isolated disarray foci, and the pathologists say that the observed cardiac lesions do not fulfill the morphologic diagnostic criteria for ACM. This is the photography of the heart. I think that the patient did have hypertrophic cardiomyopathy, and the mother also had hypertrophic cardiomyopathy with a more severe hypertrophy. In this case, we were able to do the genetic testing in the maternal aunt after the death of this mother and son, and we found a mutation in myosin binding protein C, a frame-shift mutation, truncating mutation, which was also present in the brother when we obtained sample from the autopsy. And this mutation had been previously found in 17 carriers, 8 families in Galicia. And in these families, we had sudden deaths and we had defibrillators because of high risk, clinical risk. The 13-year-old girl does not have the mutation, and in this case, we can say, okay, you don't have the risk, you can be discharged. And this is very important. Genetic testing is very useful in the evaluation of the relatives. In this case, it's a pity we didn't do it earlier because we would have found the mutation in the boy who died, and maybe we could have done something. These are other patients with the same mutation from our clinic, and you see severe hypertrophy in several of them, and these are young patients, ages 17, 39, and 45. Putting together all these patients with this myosin binding protein C truncating mutation, 51 individuals from different families, this is the survival curve. It's very interesting because if we evaluate all the frame-shift variants in the gene, here we have more than 800 patients, and the survival curve is the same. So here you see that there is an individual mutation, the similar mechanism, the same mechanism, other mutations, the survival curves are exactly the same. We need genetics to make early diagnosis, to understand the disease, and to perform a good risk stratification. Prognostic determinants related to genetic testing. Genetics may provide the correct diagnosis. So if we don't have the correct diagnosis, we are not doing really a good risk stratification. Double and de novo mutations, in that case, family history is not sufficient, because if you have a de novo mutation, there is no family history of sudden death, even if the mutation is very severe, for example. And prognosis may be associated with specific genes, and we are going to review this aspect, but also that prognosis may be associated with the different mutations. For that, we need to collect data from diseases, patients, families, genes, and mutations which is dispersed, and transform this in information for each individual that we are going to evaluate. For that, our system is to recover. We have people recovering the documents, the papers that have been published. We have now more than 70,000 papers in the database. We have people introducing the data about these different papers, and in this database, we are then able to generate reports and information, and even to draw survival curves. So let's see information about prognosis in different genes. This is 2,900 individuals with missense beta-myosin heavy chain mutations. This is the survival curve free of cardiovascular death, including sudden death, heart failure death, appropriate discharge, or heart transplant. This is the survival curve for myosin binding protein C mutations. It's significantly different. As you see, the p-value is 0.0001. Blue is that the percentage of death with sudden death. So in blue, sudden death. In gray is transplant. In pink is heart failure death. So the different events, most frequent sudden death in young individuals. This is troponin T in green, different, lower survival. This is troponin I in red. Here you see tropomyosin in purple in the middle. This is myosin light chain 2 in brown, better survival. Myosin light chain 3. Here the numbers are smaller. Actin in gray, better survival than others. Troponin C, green. GLA, Fabry disease, is the best you may have if you have hypertrophic cardiomyopathy, better cardiovascular survival free of cardiovascular death. And this is Prkg2 in brown, which is worse survival. And the worst survival in hypertrophic cardiomyopathy is LAMP2 mutations, Danon disease. It's important, here we're putting together all the patients, males and females. And in Danon disease, it's very important the difference in genders. Also in GLA, in Fabry disease, because these are X-linked diseases. So in Danon, you see the worst survival is Danon in males, severe hypertrophy, early onsets, a lot of events in young individuals. Females with Danon disease usually develop dilated cardiomyopathy, but they also have a high incidence of events. In Fabry disease, females in red are better than males in green. But also in one gene that is not X-linked, you see that females in orange with hypertrophic cardiomyopathy related to beta-myosin mutations have a better prognosis than males with mutations in the same gene. So you see, gender is an important factor. The gene affected is an important factor. However, the prognosis is not the same for all the genetic variants in the same gene, because for any of the genes, there are variants that are even non-pathogenic. In this family, we found a mutation in the beta-myosin heavy chain gene, arginine 719 gluten. This is a 15-year-old girl, asymptomatic, who comes for screening after the sudden death of her mother, who was when she was 19 years old. So this girl had not been tested and comes to the clinic. The mother had died several years ago, and the grandfather is alive with a diagnosis of hypertrophic cardiomyopathy. Would you put a defibrillator in this 15-year-old girl? Would you put it now? I can show you important information. She's 23 millimeters, no arrhythmias, no syncope, asymptomatic, no obstruction, but she's got severe late gadolinium enhancement. This could be a trigger for ICD implantation, but we could discuss about whether we have to put the defibrillator and whether we have to put the defibrillator now. But now I will show you the information from the genes. This is a missense variant in beta-myosin, so we check all the missense variants in beta-myosin. You have seen there are a lot of variants, and here is the survival curve we have seen before. But if we go to the specific variant of this family, this is the survival curve for 49 individuals, and you see at age 20, there is a 25% events, which are all of them sudden death. And the events appear in individuals that are very young, even younger than 15 years old. And the survival is very bad. When you are 50, your probability of being alive is around 20%. This mutation is located in a region of the gene, and here we are seeing regions from UniProt in the converter domain. This is a region that is involved in force generation. And if we evaluate the mutations in this region, we have 400 patients with different mutations, 47 variants, and this is the survival curve for mutations in the converter domain. So the converter domain is worse survival than the global survival of beta-myosin heavy chain mutations, but it's better than this particular mutation that is within the converter domain. We published something about that in this paper, and there we also explained that not all the mutations in the converter domain had the same prognosis. This was 2015. Now we have more information. This mutation within the converter domain is in a particular helix, 715 to 721. So if we evaluate mutations in this particular region, we have 10 variants, 189 patients, and 100 families. And you see in red, this is the survival of the helix, which is similar to the survival in the arginine 719 glutamate mutation, and different to the survival in the converter or in the whole beta-myosin gene. Interesting here to see on the right, this is the age of diagnosis, the cumulative percentage of affected carriers at different ages. So for example, in beta-myosin heavy chain, at age 50, approximately, and here we are not seeing in detail, 60% of the patients have been clinically diagnosed. But if you are thinking in the glycine 716 or in the helix 715 to 722, the percentage of patients with a diagnosis is close to 90%. So in this case, if we take all the mutations, here you say better prognosis and later onset than if you take the converter, and then if you take the 719 or the 716 or the helix. So there is a relation, earlier manifestation, more severe prognosis for these beta-myosin heavy chain mutations. In conclusion, genetic studies provide relevant information both for diagnosis of index and relatives and for prognosis. The prognosis depends on the affected gene and on the specific disease-causing mutations. A correct interpretation is essential for the correct application of genetics in clinical practice, and for that we have to gather a lot of information. Multiple genetic causes are present, and possible double impacts have to be considered. So please make complete studies, especially in patients with severe phenotypes. We have to be careful with variants of unknown significance to avoid overdiagnosis. And if we don't know whether the variant is pathogenic, we cannot make any evaluation about the prognosis, even though we know that patients with a negative genetic study may have better prognosis in general than patients with a positive genetic study. And it's important to reevaluate phenotype-genotype in the family. When we find a mutation, the mutation may explain the phenotype of the patient, but not explain the phenotype of the family, and then we have to think on additional genetic factors. It's important to use all the available information to provide the maximum benefit for the patient and for the family. Thank you very much. I'm happy to answer any questions.
Thank you very much, Dr. Lorenzo. So we will have a question after this talk. Thank you.
Hello, good evening, everyone in India, and good morning for those who are in other time zones. I'm Ram Prasad. I'm the lab director at MedGenome Labs, and it's a pleasure to introduce Dr. Hisham Ahmed, who is Associate Professor of Cardiology at Amrita Institute, and he's also the project lead for Amrita Institute of our Hypertrophic Cardiomyopathy Clinic and the registry. He also co-leads the cardio-oncology clinic at Amrita, and it was a pleasure to work with him on a nice cardiomyopathy cohort that we recently published, and which explains the kind of low penetrance phenotypes in families, large families. And the topic that he's going to talk about is HCM mimics. The phenocopies are all around us. Very important, especially in a country like India, where if not in all, in majority of the centers, the complete comprehensive phenotypic examination is not done before sending for genetic testing. And we end up doing exhaustive search for HCM gene mutations. Over to you, Dr. Ishan.
Warm greetings to my colleagues from India and abroad who have joined us. For me, it's an absolute privilege to be here among the leading luminaries in the field of HCM care. We'll listen to a couple of fantastic talks describing the HCM phenotype and the genetic architecture of sarcomeric HCM. What I'd like to talk about are a select group of clinically important disorders termed HCM mimics, which have a similar phenotypic appearance, but they're fundamentally different in terms of their pathogenesis, genetic architecture, natural history, and potential therapeutic options. Unexplained left ventricular hypertrophy is explained to a large extent by hypertrophic cardiomyopathy of the sarcomeric type with considerable genetic heterogeneity. But on the other hand, there are certain genetic and non-genetic conditions that are not caused by cardiac sarcomere mutations, but they are associated with severe left ventricular hypertrophy and its associated consequences. And these conditions are referred to as HCM phenocopies. So how common are these HCM phenocopies? So based on published data that we have, approximately 5 to 10% of patients with a clinical diagnosis of hypertrophic cardiomyopathy may eventually turn out to have an HCM phenocopy. The clustered infographic on the left-hand side of the screen is an approximate proportional representation of some of the clinically important HCM phenocopies ranging from Fabry disease to cardiac amyloidosis, the increasingly clinically relevant Prkg2 disease. There are certain malformation syndromes such as Noonan syndrome, which can present with hypertrophic cardiomyopathy, Denon disease, which is a very important HCM phenocopy, and of course Pompe disease, which belongs to the spectrum of inborn errors of metabolism. On the right-hand side, you can see a broad range of categories under which these phenocopies can be classified, and this is by no means an exhaustive list, but it represents a majority of the clinically relevant phenocopies that one may encounter in clinical practice. And of course, the very first step would be the recognition of these phenocopies. Many of these phenocopies have multisystemic involvement, and as a result, they have a unique constellation of clinical features and investigational data. Therefore, the red flags approach would be a prudent method to screen for the likelihood of the presence of these phenocopies. If there are any red flag indications as to the presence of any of these phenocopies, then this would pave the way for a full clinical investigation. Identification of these phenocopies are not only important for the diagnosis as well as a prognostication, it's also to identify a phenocopy which may have potential for specific therapy too. Now let's take a look at some of the clinically relevant HCM phenocopies, and we'll start out by looking at Fabry disease first. And Fabry disease, we know, is an X-linked lysosomal storage disorder due to alpha-galactosidase A enzyme deficiency. And based on published literature, we know that the prevalence approaches just under 1% in male and female patients of HCM who have been screened for the presence of this disease. It's very important to make a diagnosis of Fabry disease because specific therapy in the form of enzyme replacement therapy and migalastat therapy is available. Now, the principal process in identifying Fabry disease in a patient with unexplained left ventricular hypertrophy is to determine whether the red flags in terms of signs, symptoms, or investigational data are present at any stage in the sequential evaluation of a patient as demonstrated here. Starting right from the multi-generational pedigree chart, an X-linked inheritance may give us a clue that we may be dealing with Fabry disease in such a patient. In terms of symptoms, in addition to the cardiac symptoms, extracardiac symptoms such as neuropathic pain, stroke, TIA, tinnitus, or GI disturbances or hyperhidrosis may point us in the direction of Fabry disease. There may be certain physical clues like angiokeratoma or corneal opacities on slit lamp examination, which again, they are additional evidence which may point us in the direction of Fabry disease. On the ECG, in addition to left ventricular hypertrophy, the presence of a short PR interval or conduction defects again is a feature which might tell us that we may not be dealing with a typical sarcomeric HCM, and conditions like Fabry disease must be suspected. Lab tests are the tests which usually provide definitive evidence in addition to genetic testing, and of course in the lab test we can estimate the degree of activity of alpha-galactosidase A enzyme level, and also we can perform an estimation of its levels in plasma as well as leukocytes. And of course, we can also look at the level of the disease substrate in the form of lyso-Gb3. And these are definitive tests which may really point us in the direction of the clinical suspicion of Fabry disease. In terms of cardiovascular imaging, it's often characterized by the presence of left ventricular or biventricular hypertrophy, and sometimes a basal inferolateral wall distribution of LGE may be seen. This is not a very specific sign, but its presence will lead to the suspicion of Fabry disease. A low native T1 signal during T1 studies also is an important clue as to the presence of Fabry disease because the T1 values may be pushed down because of the accumulation of glycosphingolipids. An endomyocardial biopsy is not often performed in this clinical context, but if it is performed, myocytes with vacuolation and a Sudan black stain positivity may be seen because of lipid deposition. And of course, genetic testing is available for the confirmation for the diagnosis in case a pathogenic mutation has been identified. So this is a patient who was referred to us for a hypertrophic cardiomyopathy workup. And as you can see, his ECG is virtually screaming out loud hypertrophic cardiomyopathy. On the other hand, the presence of a low normal PR interval duration coupled with certain extracardiac symptoms such as a neuropathic pain, the presence of angiokeratoma and corneal opacities on slit lamp examination. The constellation of these extracardiac findings, these red flags, directed us towards Fibroid disease evaluation, and eventually he turned out to be diagnosed with Fibroid disease with the presence of a pathogenic GLA mutation. And this is the echocardiogram of the very same patient, and the apical four-chamber view clearly shows a diffuse distribution of left ventricular hypertrophy, and you can also appreciate right ventricular hypertrophy as evidenced by thickening of the right ventricular free wall. This is another patient who was eventually diagnosed with Fibroid disease, and he had presented in heart failure. And if you look at the CMR on the left-hand side, you can see there is diffuse left ventricular hypertrophy with some thickening of the right ventricular free wall as well. And in addition to that, there is thinning of the apical intraventricular septum, the apex, as well as the mid and apical lateral wall segments. He had severe wall motion abnormalities, and as you can see, there's also evidence of a left ventricular apical clot on the CMR. On the LGE sequences, there was extensive LGE distribution corresponding to the segments of thinning that we saw on the SSFP sequences. Now, switching gears to another very important HCM phenocopy is Prkg2 disease. Prkg2 disease is inherited in an autosomal dominant fashion and is due to mutations in the AMP-activated kinase, which is essentially the guardian of cellular energetics. The actual prevalence is unclear, and data is still evolving in many HCM cohorts around the world. The clinical distinction of this HCM phenocopy is the high incidence of conduction disease, and patients are often symptomatic as early as the second to third decade of life as a result of this. Of course, multi-generational pedigree charts would indicate that the disease is inherited as an autosomal dominant pattern, and the symptoms are dominated by cardiovascular symptoms and rarely by skeletal muscle weakness, and that would depend upon the type of mutation the patient has inherited. On the electrocardiogram, there are two important features which should lead one to suspect Prkg2 disease in a patient with unexplained LVH, and these two parameters are a short PR interval and pre-excitation, along with a high incidence of AV blocks, sinus node dysfunction, and SVTs, especially atrioventricular reentrant tachycardias. Elevated CK on the labs is not a reliable sign of the disease, and cardiovascular imaging shows diffuse left ventricular hypertrophy and often biventricular hypertrophy, and rarely is the hypertrophic pattern of a regional distribution. An endomyocardial biopsy is not often done these days since genetic confirmation tests are available, but endomyocardial biopsy may show myocytes with positive glycogen granules, and myofibrillar disarray is usually absent. Diagnosis can be clinched with a genetic test, which may detect a pathogenic Prkg2 gene mutation. This is a young patient with severe AV node as well as sinus node disease who was eventually diagnosed with Prkg2 cardiomyopathy at our clinic. And here on the ECG, you can clearly see evidence for a very short PR interval, definite evidence for pre-excitation. And this patient subsequently underwent permanent pacing therapy for his severe conduction system disease. And he also underwent radiofrequency modification of an accessory pathway due to repeated episodes of AVRT. On the left-hand side of the screen, you can see an apical four-chamber view of an echo of a patient with Prkg2 cardiomyopathy who had a pacemaker implant for severe conduction system disease. And as you can see, there is very severe diffuse left ventricular hypertrophy, and you can also see that the right ventricle is also significantly hypertrophied. On the right-hand side, it's the CMR image of a patient with Prkg2 cardiomyopathy, again, exemplifying the diffuse nature of left ventricular hypertrophy as well as right ventricular hypertrophy. From the standpoint of clinical data from this part of the world, we recently published a cohort of 22 patients with Prkg2 cardiomyopathy along with their 7-year follow-up data. And in our experience, the red flags approach was the most important tool which led to the identification of this very important HCM phenocopy from the HCM cohort at our institution. Moving on to another very important HCM phenocopy, which is cardiac amyloidosis, which may be of the AL type or the ATTR type. ATTR type of the mutant variety may show an autosomal dominant pattern of inheritance. Extracardiac symptoms in the form of autonomic dysfunction, neuropathy, or carpal tunnel syndrome are additional clues as to the probability of amyloidosis. There are well-recognized physical signs which may encourage us in the evaluation in the direction of amyloidosis as well. A low-voltage QRS complex on the electrocardiogram is an important clue, especially in the presence of thick hearts on the CMR or the echo. Laboratory tests are essentially aimed at identifying the underlying cause of amyloid fibril deposits, and tissue biopsy samples may also demonstrate the presence of amyloid deposits. The echo and the CMR often indicate a diffusely thickened left ventricle, right ventricle, or both, markedly reduced global longitudinal strain, and a relative sparing in the apical segments when the 2D speckle tracking bullseye map is analyzed. The cardiac MRI is characterized by suboptimal nulling pattern and often global subendocardial or transmural LGE pattern. Endomyocardial biopsy is not often done, and if done, may demonstrate evidence of amyloid fibril deposits. A genetic test confirmation is available for the ATTR mutant variety of amyloidosis. And this is a patient with AL cardiac amyloidosis, and as you can see here, there's low voltage QRS complexes in the limb leads. The apical four-chamber of the echo shows thickened interatrial septum, diffuse thickening of the left ventricular walls, and thickening of the right ventricular free wall as well. And as you can see here in the lower panel, there is relative sparing of the apical segments when the 2D speckle tracking bullseye map is analyzed. The patient did subsequently undergo source therapy for AL cardiac amyloidosis. And this is a CMR LGE sequence in a patient with cardiac amyloidosis, which clearly demonstrates global subendocardial diffuse late gadolinium enhancement in the four-chamber view, as well as in the short axis view. We're going to finish up by looking at another important HCM phenocopy, which is known as Denon disease or LAMP2 cardiomyopathy, which has an X-linked dominant inheritance pattern. The disease is characterized by a malignant clinical course in the most severely affected patients who may not survive more than 20 to 25 years of age, and they often succumb to sudden cardiac death. There are certain clinical red flags in the form of intellectual disability and skeletal muscle weakness, which may alert the physician to evaluate for Danon disease in such a patient. On the ECG, there will be massive LV voltages and, of course, the presence of pre-excitation at a short PR interval, again raising the suspicion of this clinical entity. There are certain clinical biochemical markers which may be elevated in the form of CK, transaminases, or LDH, which are valuable clinical clues. The cardiovascular imaging demonstrates diffuse and massive left ventricular hypertrophy, and the biopsy may indicate vacuolated myocyte sarcoplasm with glycogen granules and autophagic debris, and the diagnosis is confirmed by the detection of a pathogenic LAMP2 mutation. This is a typical ECG of a patient with Danon disease with marked LV forces, a short PR interval, a hint of pre-excitation, and of course on the right-hand side you can see a diffuse and severe left ventricular hypertrophy on the echocardiogram.
I would like to conclude that the accurate identification of an HCM phenocopy is ultimately dependent on a systematic roadmap, and the version of the roadmap shown here takes into account 5 major channels of inquiry, starting from the age at presentation, the clinical spectrum in terms of symptoms and signs, certain panels of blood tests which may be grossly abnormal. For example, the metabolic panel may be grossly abnormal in glycogen storage diseases, and of course, certain characteristic electrocardiographic changes coupled with imaging characteristics on advanced cardiac imaging. The integration of findings belonging to these 5 major categories will give us a reliable direction for the accurate identification of an HCM phenocopy. Not only does it achieve the diagnosis, it will enable us to accurately prognosticate these patients, counsel the family members and the at-risk family members who might need cascade genetic screening, and of course, most importantly, the identification of an HCM phenocopy for which there is specific therapy. Thank you for your patient listening, and I would be happy to take any questions in the live Q&A. Thank you.
Thanks, Dr. Hisham. I think it can't get as clear as how we have explained this. Just opening for a couple of questions. There is a interesting question from AIG. Sir, could you please ask your question, or you want me to spell out?
Okay, so there is one question to Dr. Neha. What is the impact of right ventricular involvement in RVOT obstruction?
I think that's an excellent question. And I think I probably should have mentioned that that whenever you're doing an echocardiogram, one thing that people often tend to underestimate is the role of the right ventricle. And I think along with the steps that you would do for HCM interrogation, the RVH needs to be looked out for, and especially the absence and presence of outflow tract obstruction. And that should then raise concerns about syndromes such as Noonan's that you need to consider. So a very, very good question, and thank you for bringing that up.
And while you're there, another one. What is the role of contrast perfusion echo in patients presenting with HCM with ACS? Does it really differentiate the two?
So I've got a confession to make. Basically, we have 3 cardiac MRI scanners in the unit. We tend not to use contrast echo for questions that you've asked us. And if your question, if I understand, is to distinguish the type of cardiac injury or the absence of presence of thrombus. Could you clarify the question there?
Well, if somebody has hypertrophic cardiomyopathy and they have an ACS.
Sure. So, so if I'm talking on clinical side, the first thing would be you look at your clinical probabilities. If it is you suspect coronary disease, we would straight away take the patient onto the cath lab. And if you couldn't do that, and your probability that this, so I don't think there's enough literature about the acute episodes of inflammation that we see in patients with hypertrophic cardiomyopathy. But if your probability of having coronary disease was not that elevated, our next port of call would be a cardiac MRI. I'm not going to be able to comment on the role of perfusion echo, as you say, in this segment, because that's not a modality of imaging that we use in our practice. So maybe somebody else, if they got more experience, may be able to comment on that.
I can make. Am I audible?
Yes, yes.
Okay. One, we had used echo contrast where we could not see the LV apex in apical hypertrophic cardiomyopathy. So it is an excellent technique to look at the LV apex. That is one. Two, we have used coronary CT to rule out a coronary artery disease in these patients. Third, we had also observed when we have done a myocardial perfusion imaging with maybe scan, you can also get the myocardial hypertrophy very well on that scan and also get the perfusion. Having said that, we also need to remember that like myocardial disarray, there is capillary disarray in hypertrophic cardiomyopathy. So this capillary disarray, and also because of the transmural gradient in the left ventricular myocardium, there is a microvascular dysfunction in the myocardium. So there is some amount of ischemia as the as the days go by. There is scarring. There is also microvascular dysfunction and ischemia. So it would not be easy to differentiate them, except by doing a angiography either by CT or by invasive angiography. Even there, you will only know the epicardial coronary arteries, but not the microcoronary status. One more fallout is, I have seen some of these patients being admitted as acute MI, and then because the troponin is elevated, and I am a witness to quite a few patients taken to cath lab for primary angioplasty to discover that the coronaries are normal, without realizing that troponins may be elevated in a substantial number of patients with hypertrophic cardiomyopathy. In fact, there is a lot of literature that is available, and I have seen large number of patients as well. And these are the patients who have generally a myocardial fibrosis and cardiac MRI. So there is a correlation between increase in the troponin, and myocardial fibrosis in cardiomyopathy.
Thanks for that, sir. Just a couple of questions I just wanted to direct to Dr. Hisham. There is a question, is human hepatitis C virus associated HCM is causal or a chance? Is it under-recognized? Dr. Hisham, could you clarify on this?
Yes, Ram. So that's a very interesting question. So if you look at some of the less common causes, which is associated with the hypertrophy of the left ventricle, hepatitis C virus has been identified. Yes. So the answer would be a yes. But I can't say, in my experience, I've come across a situation where I've seen a series of patients with HCV coming with hypertrophy of the left ventricle. But in literature, there have been numerous case reports and quite a number of case series which have documented that phenomenon. So the answer would be a yes.
Yeah, the last one for you is from Dr. B. Somaraju. He asked for babies born of diabetic mothers, their hearts are HCM mimics, something like
Yes.
a copy. So could you comment on that?
Yes, so that is true. So we frequently get consults from the pediatric cardiology side of our institute for children who are born with thick hearts in the who are found to have thick hearts in the neonatal period. And one of the definite check boxes when we evaluate such a neonate is to find out whether the mother had been a diabetic. So definitely yes, there are metabolic pathways which have been clearly elucidated, which explains this hypertrophic phenomenon in the left ventricle to neonates born to diabetic mothers. Yes.
May I also add something that if you follow them up, it always disappears.
I agree.
There's another question, impaired relaxation versus compliance. How does one clinically differentiate between the two? Would like to take up that.
I think it was related to one of my slides. So I think it's a very difficult thing to differentiate clinically. Mostly it needs an invasive assessment by high impedance catheters, like where we find out the slope of EDP-VR. But having said that, there are some effort to find out compliance by 3D echo based volume and pressure studies. But non-invasively, it's very difficult to find out. But that statement will be true for almost all diastolic dysfunction. Like, because diastolic is some.
Yeah, there is Dr. Krishnaraju here. There is a complicated formula on echo, which they take volumes, thickness, ejection time, and LV filling, everything into a formula, and then try to make a diagnosis of compliance failure. But it is too messy to do it in a clinical setting.
Yes, sir.
Okay, can I take a question for Dr. Lorenzo? There are a few questions.
Sure, sir.
Yeah. Okay, hi, Prasad. Is contemporary genetic testing useful for sudden death risk stratification? Can you tell us about your experience? That's the question.
I understood you. What is the contemporary role of genetics in risk stratification? Is that the question?
Yes.
Okay. I think that is completely infravalued, the evaluation of genetic testing for prognostic evaluation. So if you are talking in hypertrophic cardiomyopathy, there was initial papers that suggested that there were malignant and benign mutations, and with confirmed results later, but all of them were based in small studies. It's clear that the first factor to make a prognosis is to know the right diagnosis. We have seen that phenocopies and hypertrophic cardiomyopathy in the European Society of Cardiology, we say, is unexplained hypertrophy. But finally, it's not the same if you have a Fabry disease, a Denon disease, or a sarcomeric disease. So this is important when we make a prognosis, what we are making the prognosis. It's in the European Society of Cardiology calculator. For example, you are going to put family history of sudden death. But if you have a de novo mutation, family history of sudden death is not going to be present. So in some way, we can use now this information in genetics. We can use if you have two mutations in a patient in the family who dies suddenly. This should this be a risk factor for other family members? This sudden death, if they only have one mutation, these aspects are important. In my opinion, what I have shown you, which is something that is really there is a lack of publication. We are reviewing the whole literature, putting the data together. We have very good information to start working on the prognostic information. And I guess at the same as in dilated cardiomyopathy, that now we know that lamin mutations, and particularly truncating mutations or some missense mutations or filament C, are important to decide to put in the defibrillator. I am sure that we are going to have genetics in the risk stratification very soon.
Right.
Thank you.
There's one more question. How should we go genetic counseling regarding transmission of HCM for prospective mother?
How should we provide genetic counseling to the mother? I think genetic counseling is one of the key aspects that in any consultation with a hypertrophic cardiomyopathy patient, it's important to provide genetic counseling, at least in the first consultation. Okay. So you don't have to wait until they are pregnant. You have to explain that, okay, one part of the disease is we have to do a full pedigree of the family to try to understand what is happening in the family, to try to detect patients or other individuals at risk. And with our patient, we have to explain that this may be a genetic condition. In many cases it is. That sometimes there is no familial transmission, but that it's possible that they transmit the mutation to the family. And then to give a good genetic counseling, it's important we can do a good risk stratification. And if we have the genetics, we can give more information. It's not the same hypertrophic cardiomyopathy with an early onset and severe disease. As I have some example in some beta-myosin heavy mutations, that to have a benign mutation that 50% of the carriers are not going to develop the disease. So if you are going to have a baby or decide to have a baby and the mutation you have is benign, or the clinical course in the family is benign, you have to give a different information than if you have a family with a lot of sudden deaths.
Yeah, it's very complex because particularly when you have a mutation in sarcomeric genes, where country like India, there is a consanguinity and endogamy is practiced. You may see the parents are absolutely fine with the heterozygous mutation, but the children will be dying with the homozygous mutation. That's more consideration for countries where they practice endogamy.
Yeah, yes, it's really important.
By the organizers that we are running out of time. Thank you all the speakers for an excellent session. We all learned a lot, and let's move on to the next session. Thank you all.
Thank you.
Thank you. Thank you very much.
Thank you.
So we'll move on to the next session of session 2. So we have three very interesting talks, and I'd like to introduce the chairpersons for the session, for the second session. One of the chairpersons is Dr. Praveen Verma, who's professor and head of CVTS, Amrita Institute of Medical Sciences. Dr. P. Chandrasekhar, who's the chairman of the Cardiothoracic Surgical Program and Transplant Services at Coimbatore GKNM, and Dr. K.K. Sethi, chairman and managing director, Delhi Heart and Lung Institute, New Delhi. So over to you, Dr. Praveen Verma, for the session 2.
Yeah, thank you, Hisham. Let us move on to the next topic, that is management of obstructive hypertrophic cardiomyopathy. And it's my great pleasure to invite Dr. Muthaiya Subramaniam to deliver his talk. So Muthaiya Subramaniam was a colleague of us in Amrita. Now he is a consultant cardiologist and electrophysiologist at the prestigious AIG Hospital in Hyderabad. Over to Dr. Muthaiya.
Good evening. So I'll be speaking to you about the management of LVOT obstruction. Let's start with a case. 55-year-old male, no family history of HCM or sudden cardiac death, obstructive HCM with refractory exertional syncope, an ECG with a QTC of 430 milliseconds, echo we can see with LVOT asymmetrical septal hypertrophy of roughly 21 millimeters, elongated mitral valves, dilated left atrium and grade 3 SAM, with a resting LVOT gradient of 64 millimeters per mercury. Cardiac MRI didn't show LGE, and ESC-SCD risk score of 3.8%. The reason for showing this is to show that there is a wide spectrum of clinical and anatomical variations in hypertrophic cardiomyopathy. And when choosing a treatment modality for our patients, we need to choose the best modality that will give the best long-term implications for our patient. Left ventricular obstruction is present in most patients, either at rest or during exercise. But the actual mechanism behind the LVOT obstruction is often a very complex phenomenon. As Dr. Olivoto said, it really does seem like this is a pathophysiological conspiracy, and an evil mind has masterminded all of this. Because, for example, elongated mitral valve with abnormal papillary muscles all floating around in a very small ventricle. And to add to all of this, the LV is hypercontractile, which further creates the drag forces responsible for SAM. The greater the surface area of the leaflets exposed to the drag force, the more the LVOT obstruction, and hence the vicious cycle continues. And this is what is shown in the figure here with accelerated blood flow in the LVOT cavity. Hypertrophic cardiomyopathy mitral valve malformations have been identified at all levels. They can occur at the leaflets with an elongation of the anterior and posterior mitral leaflets, and also in the submitral apparatus affecting the papillary muscles and chordae. These can either be functional or acquired malformations, but in the end, they all join together to create systolic anterior motion of the mitral leaflet. And this adds to the gradients and the obstruction and the vicious cycle thereafter. But it's important to identify these abnormalities because there are therapeutic implications, especially when trying to choose between surgery and alcohol septal ablation in some patients. Here we can see 3 patients with 3 different levels of obstruction. In the first patient, we can see a typical LVOT obstruction caused by SAM and a gradient thereafter. Here we see a patient with a mid-ventricular obstruction. And here the issue is not the SAM and the LVOT, but a sphincter-like mechanism in the mid-cavity gradient. This has 2 effects. One, it creates a gradient in the mid-cavity, but it also causes a dilation and thinning of the apical segments of the heart. This can often lead to ventricular arrhythmias. And although the patient's gradients may not be as severe as the other patients, they often have far worse symptoms. And on the last, we can see a patient where there is not so much left ventricular hypertrophy at the basal septum, but there is abnormal papillary muscles in the form of an apicobasal bundle and anterior papillary muscle. And this is what is creating the LVOT gradient in the SAM in this patient. It is crucial to understand the level and mechanism of obstruction before deciding the type of management in these patients. Dynamic LVOT obstruction has long been considered the primary driver of symptoms and complications in HCM. More than half of patients with HCM with resting gradients develop LVOT on exercise. Those with resting gradients have poor long-term outcomes, as shown in this study. But those with obstruction that is only provocable, that is labile HCM, often have a far less lower rates of adverse events. And hence, it becomes very important not only to differentiate your obstructive and your labile HCM, but also to make sure that we rule out a provocable gradient when we look at patients with non-obstructive versus a labile HCM, because this often has a prognostic factor in these patients. Now, when we come to the principles of management, the goal of treatment of a HCM patient is relief of morbidity and improvement of survival. And for some patients, the predominant focus is on symptom relief, but this has to be achieved while minimizing harm and impairment of longevity. Now, the guidelines, this algorithm was suggested in 2008, and it focused on medical therapy and advanced therapies such as septal myectomy and ablation in patients who are refractory to medical therapy. Now, in 2014, not much has changed. The guidelines have remained the same. First, there's a trial of medical therapies, be it beta blockers, calcium channel blockers, or disopyramide, followed in refractory cases by septal reduction therapy, be it alcohol septal ablation, or the better choice in most patients, septal myectomy. In case, for some patients, there may be a role of other procedures such as a mitral clip or AV synchronous patients, but this is not for all patients. Beta blockers remain the backbone of treatment in HOCM. The circulatory effects of beta blockers were first studied in 1964 in 10 patients with hypertrophic subaortic stenosis. In this study, they found that beta blockers had little effect on the severity of the obstruction at rest, but reduce the intensification of the obstruction produced by exercise and isoproteinorol as shown here in this slide. The mechanism by which a beta blocker works in HCM is multidimensional, but basically it's related to the reduction in myocardial oxygen requirements resulting from a reduction in wall tension, velocity of contraction, and heart rate. Now, traditionally, multiple beta blockers have been used: nadolol, atenolol, propranolol, bisoprolol, and metoprolol, but no specific agent has been found to be superior to others. That is, in general, once we start these beta blockers, the goal is to titrate to the maximum tolerated doses based on the patient's symptoms, blood pressure, and heart rate response. There are a few studies that have found that nadolol and bisoprolol have been equally effective in some patients. And it's very important to make that we continue to up-titrate the patients when they come for follow-up. Here, we see a patient, 32-year-old male with exertional angina, NYHA class 3, sarcomeric HCM with a resting LVOT obstruction gradient of 52 millimeters. He has been on bisoprolol 5 mg OD, but continues to be symptomatic. So at this point, we can see his echo here. So what are our choices here? Do we persist with the same drug? Do we change a drug? Or should we go to advanced septal reduction therapies? So disopyramide is a very important drug because it has a strong negative ionotropic agent, and it improves the balance of the myocardial oxygen supply and demand within the heart. And here we can see when simultaneous measurements of the left ventricle and aorta were made, and IV disopyramide was given in a patient, you can see the sudden reduction in the LVOT gradient as shown here. So disopyramide works, but the question is it a first-line agent or a second-line agent? And oftentimes, as shown in this study on the right, disopyramide reduces the LVOT gradient and provides symptom relief in the patient that we just saw, and a patient who is resistant to a beta blocker and a calcium channel blocker. So it is a very good add-on or second-line drug, and sometimes we can start this upfront in some patients as well. But oftentimes, as a second-line drug, it is very good. But there are a few things that we need to know regarding the dosing and monitoring of patients when they're on disopyramide. Prior to initiation of the drugs, it's important to have a baseline assessment of the renal function, electrolytes, and also look at the ECG for looking for QTC prolongation, especially after 48 hours. Therapy with disopyramide can be continued as long as the QTC interval is less than 525 milliseconds in patients with normal QRS complexes and less than 550 milliseconds in patients with baseline interventricular conduction delays. Now, the controlled release preparation is not universally available. As in India, we use the immediate release preparation. And the other important thing to look for is that disopyramide has strong anticholinergic effects. So we should not be using this in patients with a severe benign prostatic hyperplasia, urinary retention, or glaucoma. And once the creatinine clearance is less than 30, we need to be careful regarding dose adjustments. For patients with medically refractory LVOT obstruction, we've tried multiple drugs, even dual therapy, it's not working. These are the patients that we can consider for intervention and surgical management of LVOT obstruction. So what are these indications? Symptoms, we need to consider their surgical risk, exercise capacity, the mitral valve anatomy, and the degree of mitral regurgitation are very important. Does the patient have atrial fibrillation on oral anticoagulation? And what is the target quality life for the patient? This also has to be discussed individually with each patient, especially. And definitely economic issues involved not only with the procedure, but post-op care as well. Here we see a 50-year-old female with a myosin heavy chain 7 mutation. Patient had refractory syncope, had a respiratory, despite 2 drugs and IV septal thickness of 24 millimeters. There was a resting LVOT gradient of 78 millimeters per mercury. So in this patient, we opted for alcohol septal ablation. And you can see that the lighted area here is actually the injection of contrast through the septal coronary, as shown here. So in this patient, after alcohol ablation, the LVOT gradient reduced from 78 to 10 millimeters resting gradient. And the patient is now NYHA class 2 with 24 months of follow-up. So alcohol septal ablation definitely has a role in the arsenal of treatment strategies when when considering hypertrophic obstructive cardiomyopathy. It emerged as a treatment option more than 20 years ago. And one of the longest follow-up studies that we're showing here is a 17-year-old follow-up study of 952 patients. And they estimated 5-year survival after alcohol ablation was roughly 96%. In this study, they found that the re-interventions were in 17% and a pacemaker was implanted in 10%. So relief of LVOT obstruction in a majority of patients is a noteworthy achievement of alcohol septal ablation, especially for patients, and this is important, at a high surgical risk who may not tolerate a septal myectomy. Yet the result should still be considered inferior, that is the alcohol septal ablation inferior for patients who have an option of surgical myectomy, and this is an important point. But when we consider a patient for alcohol septal ablation, the number one thing is to look for a proper patient selection. And the prerequisite is identification of one or more appropriate septal perforator arteries that supply the correct part of the basal area of the septum. Oftentimes, as you see in a patient on the left, you can see that these septal arteries are often present, and these are good cases to do. But often you will see a small septal artery or a septal perforating branch that preferentially serves the right ventricle as on the right. In these cases, it becomes difficult. The other thing to take into consideration is that we cannot control the amount of alcohol that is given. We can control the amount, but there is a lot of intricate network of anastomosis within the basal septum. And hence, we cannot limit the area of the myocardial ischemia that occurs after alcohol ablation. So this can lead to collateral damage, including complete heart block. The other thing to take into consideration is there is structural heterogeneity of the LV outflow tract and the mitral valve in HCM. And this often influences the selection of candidates for alcohol ablation. Patients with mitral valve abnormalities who will need mitral valve interventions often will do better with a septal myectomy. But that is a balance. The more alcohol we give, the more you reduce the septal thickness, and the more the gradient comes down and the better the patient feels. But is too much means does too much alcohol create more arrhythmic scar, as we can see here? And is the scar created by alcohol arrhythmogenic? In a recent multicenter European study shown below, appropriate ICD shocks or ventricular tachycardia and fibrillation were 8-fold more common after septal ablation than septal myectomy. And hence, mid and long-term arrhythmogenic potential of septal ablation cannot be ignored and plays an important role in directing patient selection for ablation towards older patients. The management of obstructive hypertrophic cardiomyopathy in patients with drug-refractory symptom has long been debated, and it's primarily between two things: surgical myectomy or alcohol septal ablation. So decision-making in these patients requires consideration of few things. 1, the procedural risk. 2, expertise and efficacy of treatment. And 3, the long-term impact on the patient's survival. Septal myectomy remains the gold standard treatment of HCM patients with LV outflow obstruction. Alcohol ablation has some advantages, especially since you can avoid the discomfort, anxiety, and recovery time with surgery. But nevertheless, the technical limitations of alcohol ablation represent major obstacles. And hence, when a patient is capable of having or is a low surgical risk, septal myectomy is the way to go. But what are the other options? And these other options have come to the fore more maybe in the last 5 to 10 years. One is offering septal reduction using radiofrequency ablation. Second, the role of AV sequential pacing. Third, metabolic modifiers, drugs. And fourth, disease modifying treatment. Briefly, I'll describe all of these. So, patients who are not suitable candidates for surgical myectomy and alcohol septal ablation can get benefit from radiofrequency catheter ablation of the hypertrophied septum. Now, radiofrequency energy is very effective modality, but it has to be targeted, and it has to be targeted to the area of the maximum septal mitral leaflet contact time. And at this time, we use two things to help us. One, multimodality imaging can help to not only to visualize the area or the transition zone and the higher pressure zones where the obstruction really is, but also the use of an ICE catheter during the procedure can allow us to show that we have proper contact at the area of interest, that is at the point of the mitral leaflet and septum where they connect. And this makes the procedure is safe because we are able to also avoid the conduction system also during this kind of ablation procedure. This is a meta-analysis of studies that have looked at septal reduction using radiofrequency ablation. And what we can see here is there's roughly 80 to 90 patients that were included in this analysis. And all these patients were chosen for radiofrequency ablation because of high surgical risk or not being suitable for other treatment options. We can see significant changes in baseline LVOT gradients before and after the ablation, as well as a reduction in septal thickness, ranging anywhere from 1.5 mm up to even 10 mm with this technique. The meta-analysis concluded that this technique used in the correct patients led to significant reduction in LVOT gradient, septal thickness, and NYJ class, and was a relatively safe and effective procedure. Now, another option in patients with disabling symptoms of HOCM who may not be very good surgical candidates is percutaneous echocardiographic guided intramyocardial septal radiofrequency ablation. And this was described by a Chinese group in 2018, where they used a radiofrequency needle that was inserted transapically to reach the basal septum, and radiofrequency energy was given from the inside out. They were able to show a reduction of up to 10 millimeters in septal thickness after the procedure, as well as, if you can see at the bottom of the slide, that the scar caused by the radiofrequency ablation, when they serially monitored with imaging studies, shrunk after 6 months. And there was a persistent reduction in LVOT gradients up to 1 year of follow-up. So this is also a treatment option that is available. Second, what is the role of pacing as a form of therapy? This has been described for a long time. It has come back maybe in the last 5 to 10 years. But what we need to understand is a few things. This on the left, we see a patient with LVOT obstruction due to SAM. So what happens? When the septum is activated through the normal conduction system, the septum is activated from the base to the apex. That is, the base contracts first and the apex contracts second. So this is what happens normally. How can we use this to our advantage? When we do an RV pre-excitation or an RV apical pacing, we can reverse this activation. Take it for granted that you have complete ventricular capture during pacing. You will now be able to capture the ventricle from base to apex. And this delayed thickening or bulging of the proximal septum can limit the amount of outflow tract narrowing and contributes to preventing dynamic obstruction. The other mechanisms involved in pacing are reduced hypercontractility and limitation of SAM as well. Long-term outcomes of sequential AV pacing studies. The largest follow-up is that of 18 years. And you can see that there was significant reduction in the baseline gradients in the post-implantation period, which maintained during final follow-up as well. But there's a few controversies regarding pacing, and one is the effect on diastolic dysfunction, because hence we are doing RV apical pacing, we are creating LV dysynchrony, and whether this has long-term effects on the LV systolic and diastolic function is still not known. A group has started enrolling patients in the TRI-CHAMPION trial to see if biventricular pacing is superior to even the sequential AV pacing that is currently available. And when we come to metabolic modifiers, non-invasive studies have demonstrated that myocardial efficiency is significantly impaired in HCM patients. The potential mechanism for this is that myocardial efficiency is represented by an altered substrate metabolism in these patients. And to say this further, in a hypertrophied septum, they have found that there is reduced glucose metabolism, and rather the myocardium switches to free fatty acids for energy production. And free fatty acids are a less effective energy source for the myocardium compared to glucose. So a few drugs have been tried which have played in this pathway, that is the switch of free fatty acids to a glucose metabolizing pathway. Both drugs, Hexane, although it did show symptomatic benefit, it had a narrow therapeutic window with hepatotoxicity and neurotoxicity, and hence it was not pursued. Trimetazidine, although it showed results in some studies, the results were not consistent. So there is no great positive studies in terms of metabolic modifiers as yet. Over the next 10 years, we expect to see several therapeutic options come to the fore, especially in terms of disease-modifying therapies. Few have been tried with less success, including ranelizine, which targeted the late sodium channel pathway and calcium homeostasis, and losartan as a renin-angiotensin inhibitor. But both trials failed to show benefit with these medications. On the other hand, mavacamten was a first-in-class small molecule selective allosteric inhibitor of cardiac myosin ATPase, which directly acted on the actin-myosin cross-bridge formation. We'll have the principal investigator of the trial, Explorer-HCM, speak to us later in the meeting. But just briefly, Explorer-HCM showed that with mavacamten treatment, patients improved their exercise capacity, LVOT obstruction, and NYHA functional class in Hokum. The management of obstructive HCM is constantly evolving with new interventional and therapeutic strategies. Novel approaches attempt to reduce and hopefully prevent the development of severe HCM phenotypes, improve symptom control, and disease-related complications. But we need to keep in mind that the clinical management of patients of HCM should be guided by an in-depth knowledge of multiple mechanisms, since it is there are so many components of this disease. Complex mechanisms of the energy, metabolic, and electrophysiological levels all need to be taken into consideration. And tailored management not only of the disease, but other modifiable disease manifestations should also be pursued, including lifestyle counseling and prevention of comorbidities. Thank you.
Thank you, Dr. Muttaya, for that wonderful talk.
Good evening. So I'll be speaking to you about the management.
Can we move on to the next talk? Praveen?
Yes, please, go ahead.
It's my great pleasure to introduce to you Dr. Hudson B. Schaff, who is the consultant cardiothoracic surgeon and also the prestigious Stuart W. Harrington Professor of Surgery at the Mayo Clinic, Rochester. He's a surgeon with a rare blend of intellect, knowledge, skill, and innovation and compassion. A teacher par excellence, a researcher and a mentor, and one of the largest in the world in the experience of surgery for hypertrophic cardiomyopathy. Next slide, please. Next slide.
Good evening.
No,
and thank you for the opportunity to participate in this symposium on hypertrophic cardiomyopathy and to present our experience on myectomy. I have no conflicts of interest to disclose, but I do want to acknowledge the research support that we've received from the Paul and Ruby Tsai family. Also, I want to recognize the effort of these research fellows who have participated in our hypertrophic cardiomyopathy surgical outcomes group and developed much of the data that I'll share with you subsequently. I recognize that most of the attendees of this meeting will be physicians and cardiologists, and there will be fewer surgeons, so I'll minimize the technical aspects of myectomy and focus on the selection of patients, only a brief overview of surgical techniques, and discuss the management of mitral valve regurgitation and anomalies, as well as operation for non-obstructive hypertrophic cardiomyopathy. In general, septal reduction therapy, especially septal myectomy, is reserved for patients who are symptomatic despite adequate medical treatment. But it should be remembered that medical treatment is targeted at the relief of symptoms, and there are really no data to support the routine use of medications to improve survival or prevent progression. This may change with the availability of mavacamten, which is a drug that reduces hypercontractility and may be an important therapy in the future. Now, the profound symptoms that many patients with obstructive hypertrophic cardiomyopathy have can be understood by examining the hemodynamic effects of obstruction. In this study, we looked at stroke volume after augmentation in patients with fixed aortic obstruction, as is the case in aortic stenosis versus hypertrophic cardiomyopathy. And in patients with fixed obstruction with provocation, say with a PVC or with exercise, there's an increase in stroke volume. Whereas with hypertrophic cardiomyopathy with provocation, either a PVC or exercise, stroke volume actually decreases. And this accounts for the great fatigability that many patients experience. You can see that postoperatively, after aortic valve replacement or septal myectomy, there is a normal increase in stroke volume with provocation. Outflow tract obstruction is important because it is very common in patients with symptomatic hypertrophic cardiomyopathy. This is a classic study by Dr. Marin and his colleagues that found that obstruction was present in 70% of patients who are symptomatic and present to their Hypocm clinic. It's important to recognize that half of the obstructed patients are only obstructed with provocation. So it's critically important to use provocative maneuvers to try to uncover obstruction in symptomatic patients. But surgery may also improve the late outcome of patients with obstructive hypertrophic cardiomyopathy. This is a study by Steve Amon that built on the natural history study by Dr. Marin. The natural history study documented that patients with obstruction, shown in the orange line, have poorer survival than patients with hypertrophic cardiomyopathy without obstruction, shown in the green line. The patients in the blue line are patients from our clinic who underwent septal myectomy for obstruction, and their survival very closely parallels survival of patients without obstruction. So it appears that successful myectomy elevates the survival from that of obstructed patients to that of non-obstructed patients. Additional evidence that there's a possible survival benefit in patients who undergo septal myectomy is seen in this study by Chris McLeod, who looked at ICD discharges over time in patients who had undergone myectomy versus those who had no operation. By 8 to 10 years of follow-up, almost 25% of patients had had an ICD discharge if they had not had myectomy. In contrast, the rate of ICD discharge was dramatically lower in patients who had myectomy. Now, the data that I'll show you on surgical technique and outcomes is derived from our experience with 3,600 patients who had septal myectomy through April of 2019. I suspect that we're very close to 4,000 operative patients at this time. We began the operation using a low oblique aortotomy. The operation that we use differs a bit from the classic Morrow myectomy. We incise the septum just to the right of the nadir of the right aortic cusp and carry this incision upward and then leftward over to the anterior leaf of the mitral valve. This is what we call the first cut, shown in the inset. I tell our residents that once you do this first cut and you see it wide open, as seen here, you'll be successful about 80% of the time. Here you can see on the excised specimen the contact lesion made by the anterior leaf of the mitral valve. And the reason I say 80% of the time is that the critical part of the operation is removal of the distal portion of the hypertrophied septum. To do this, we rotate the heart posteriorly with a sponge stick. You can see the sponge stick here. And that brings that distal septum into view. And we then use a second cut at this level to remove that distal septum. We regularly measure intracardiac pressures. Of course, we use echocardiography during surgery, but we directly measure LV and aortic pressure before and after myectomy. In this particular patient, the gradient at rest was 124 millimeters of mercury, shown here. And after a PVC, the gradient increased to 196 millimeters of mercury. After myectomy, there's no gradient at rest or after a PVC. Now, for the surgeons in the audience, if you remember a single slide from the presentation, I hope you'll remember this one. This is a patient referred to us who had had surgery elsewhere. And you can see on the echocardiogram, there's still systolic anterior motion of the mitral valve. And you can see the area of septal excision here. As shown in the illustration by the arrow, this area of septal excision was not carried far enough into the ventricle. And this is the reason for failure of myectomy in 90% of patients. It's important to understand for two reasons. First, it helps you understand how much muscle and how far to take muscle during the initial operation. And second, it's important to understand during reoperation. If you reoperate on this patient because of residual obstruction, don't take more muscle from just beneath the aortic valve because that risks creating a VSD. You need to take more muscle distally. When we see patients preoperatively, we give them figures such as this. We tell them that the risk of operation is relatively low. In fact, at our institution, the risk of a septal myectomy is the lowest of all the cardiac surgical procedures that we do. We expect that after surgery, their gradients are reduced to at least single digits, and over 90% of patients will have improvement in their symptoms. As regards long-term survival, there's two important points to make from this analysis that extends survival out to 25 years after surgery. The first is that there's a difference between survival of men, shown in blue, and women, shown in red. The survival of men parallels an expected survival curve adjusted for age out to about 15 years. And you can see that beyond 15 years, the expected survival with the dotted line is slightly better than the survival of patients who undergo septal myectomy. In contrast, women seem to do less well compared to expected. Their survival parallels expected survival only to 5 to 7 years. And beyond that, survival is considerably lower than expected for women. We don't fully understand the reason for this, and perhaps we can discuss this further after the presentation. Now, it really doesn't matter, at least in our surgical experience, whether the patient is gene positive, gene negative, or has a variant of unknown significance. The cumulative mortality of patients after surgery is the same regardless of their genetic status. What about alcohol septal ablation? At our clinic, the cardiologists prefer septal myectomy for most patients. The number of ablations done each year is shown in red. We continue to do alcohol septal ablation, and all patients who come with obstruction and need septal reduction are counseled about the availability of both of these procedures. However, in general, we would advise ablation for patients who are poor surgical candidates and for the occasional patient who's simply fearful of an operation. The reason for favoring myectomy for most patients are illustrated on the next several slides. This is a cardiac MR of a patient who's had alcohol septal ablation, and you can see the large volume of septum that's been infarcted during the procedure. In addition, if you look at MRIs late, you can see that there's a considerable amount of scar tissue. And in contrast, after septal myectomy, there's no discernible scar on cardiac MR. Now, there's debate about whether the scar leads to arrhythmia, but we have certainly seen that. This is a 66-year-old woman who actually walked into the emergency room 2 weeks after ablation in sustained ventricular tachycardia. In addition to the potential for arrhythmias, alcohol septal ablation seems to be less effective in patients with higher gradients. In this analysis, we compared the outcome as regards gradient relief of patients undergoing alcohol septal ablation, shown in the red line, with those patients that have septal myectomy. On the x-axis, you can see that the pre-intervention gradient really did not affect the post-intervention gradient in patients undergoing septal myectomy. In contrast, the higher the pre-intervention gradient, the higher the residual gradient after alcohol septal ablation. In addition, in our experience, relief of symptoms is better with septal myectomy than alcohol septal ablation. And this improved symptomatic relief translates into fewer interventions postoperatively. The red line shows freedom from reintervention in patients undergoing alcohol septal ablation, and approximately 40% of patients will require repeat procedure by 8 to 10 years after the initial ablation. Now, what about mitral valve disease in patients with hypertrophic cardiomyopathy? Mitral valve abnormalities may be part of the phenotype of the disease, but there also may be acquired intrinsic mitral valve disease in patients with obstructive HCM, and there may be mitral valve regurgitation related to SAM. This is very common. Mitral valve abnormalities in hypertrophic cardiomyopathy can be categorized as follows. There can be displacement of the papillary muscle. There certainly is hypertrophy of the papillary muscle. There can be false cords or muscle bundles. But these are usually not of much importance, at least surgically. What are important are abnormal insertion of papillary muscles and possibly elongation of leaflets and chordae. This pathologic specimen shows an anomalous papillary muscle inserting into the anterior leaflet of the mitral valve, as illustrated in the arrow. Here's an intraoperative photograph, and the forceps are on an anomalous papillary muscle inserting into the anterior leaflet of the mitral valve. Now, the importance of recognizing this are shown in the next slide. An anomalous papillary muscle that inserts into the body of the anterior leaflet can contribute to outflow tract obstruction, and you can see the narrowed area of outflow by the arrows. This is what we would call a type 1 anomalous papillary muscle. In contrast, if the papillary muscle inserts directly into the free edge of the anterior leaflet, what we call a type 3, the muscle does not contribute to the outflow tract obstruction. Now, here's a patient who underwent surgery, and you can see the anomalous papillary muscle shown by the arrow inserting into the anterior leaflet of the mitral valve. And you can see how the anomalous muscle narrows the outflow tract. But you have to be careful, because if you look at this anomalous papillary muscle closely, you'll see that one head inserts into the body of the anterior leaflet, and the other portion of the papillary muscle has chordal attachments to the free edge. So when you remove this papillary muscle, and this is what we would call a type 2 anomalous papillary muscle, you have to be certain to remove only that part that inserts into the anterior leaflet and contributes to obstruction. Now, the anterior leaflet and even the posterior leaflet can be elongated in people in patients with obstructive hypertrophic cardiomyopathy. It may be part of the phenotype, but the leaflet length in our experience is not related to the gradient. And in fact, leaflet length is not related to relief of the gradient. And for that reason, we think that plication is unnecessary with an adequate myectomy. Now, what about SAM-related mitral regurgitation? Well, first, let's talk about associated intrinsic mitral valve disease, because leaflet prolapse or ruptured chordia are special problems in patients with obstructive hypertrophic cardiomyopathy. These patients can present acutely with pulmonary edema, and it's really difficult to treat a patient with a ruptured cord and a prolapsing mitral valve leaflet who has systolic anterior motion, because medical management for the mitral regurgitation would involve afterload reduction, which then increases the gradient and the degree of SAM-related mitral regurgitation. So these patients really should go forward with surgery. And it's a particular group of patients for surgeons to appreciate, because there's a tendency to default towards mitral valve replacement for such cases. Some may argue that, well, a mitral valve replacement gets rid of the mitral regurgitation as well as relieving outflow tract obstruction. But we feel it's best to do a myectomy and a mitral valve repair. And the reason is this. If you look at survival of patients with obstructive hypertrophic cardiomyopathy and mitral valve repair, shown in blue, it is superior to patients who have mitral valve replacement, shown in the green. Now, SAM-related mitral regurgitation is usually characterized by a posteriorly directed jet. If you look at the two panels, A and B on the left side, you can see the color signal directed posteriorly in a classic SAM with classic SAM-mediated mitral regurgitation. And in B, after outflow tract obstruction is relieved and there's no further SAM, mitral regurgitation is eliminated. On the other hand, in the panel on your right side, you see a jet that is either central or slightly anteriorly directed. This patient did not have intrinsic mitral valve disease, rather had SAM-mediated mitral regurgitation. And in panel B, after elimination of outflow tract obstruction in SAM, there's no further regurgitation. This is important to recognize. What we do when we see a patient who has a jet direction that's not classically posterior, we proceed with septal myectomy and then look at the echo after bypass to see if the regurgitation is relieved rather than defaulting to a mitral valve intervention. In our experience, the jet direction is helpful. I mean, it has a positive predictive value of over 90%, but the negative predictive value is only 17%. So when you have a posteriorly directed jet, it's almost certainly SAM-related, but if you don't have it, it doesn't mean it's not SAM-related. The severity of the SAM on the preoperative echo does not change our strategy, and we believe that the adjunctive techniques such as leaflet plication, augmentation, alveoli suture, et cetera, are unnecessary for almost all patients. As we stated below, the adequate myectomy, the adequate length of the myectomy relieves both the SAM and the mitral regurgitation in almost all patients. So how many exactly? Well, in this study, we looked at about 2,000 patients undergoing myectomy to examine the incidence of mitral valve procedures. Of the patients that underwent myectomy during this particular interval, 2,000 of the 2,107 had myectomy, subaortic myectomy. We excluded those patients with apical myectomies and so forth. Of the 2,000 patients that had myectomy, about 100 of those patients were known to have intrinsic mitral valve disease. So these patients had something done to the mitral valve. So we were left with 1,900 patients with no intrinsic mitral valve disease that was identified before surgery. And the question is, how often do you have to do anything to the mitral valve? And the answer is not very often. 96% of the patients were treated with myectomy alone. Now, this is highlighted further when you look at the patients that had something done to the mitral valve. Of those patients, 33 had the intraoperative diagnosis of mitral valve disease, and we injured the mitral valve, leading to repair in 12 patients. So if you look at the patients who truly had no intrinsic mitral valve disease, the incidence of a mitral valve procedure was less than 2%. And mitral regurgitation was eliminated in almost all patients postoperatively. So the take-home points is that adjunctive mitral valve procedures are unnecessary in most patients. Overall, we perform mitral surgery in about 10% of patients, but that includes patients with intrinsic mitral valve disease. And if you don't have intrinsic mitral valve disease, the chance of needing anything done to the mitral valve is less than 2%. Remember that central mitral regurgitation can be SAM-mediated mitral regurgitation, and direct manipulation is rarely indicated. And also inspect carefully for anomalous papillary muscles. Now, a final group of patients that we seem to be seeing more often are those with calcific mitral valve disease. And if you'd asked me 10 years ago, can you have calcific mitral valve disease and dynamic outflow tract obstruction, I'd say no. But there are clearly patients that have marked calcification of the mitral annulus leading to inflow tract obstruction who can have residual leaflet SAM and obstruction. Here's such a patient who has a heavily calcified mitral annulus, and you can see the systolic anterior motion of the mitral valve in the upper left panel, and the highly calcified mitral leaflets and annulus in the lower right panel. This is the inflow gradient, which was approximately 10 millimeters of mercury mean with a peak gradient of 19. This is the intraoperative echo on that patient. You can see he had SAM and mitral stenosis. This is the gradient before myectomy. There was no gradient after myectomy. And here's the mitral valve after myectomy. Now you can see it doesn't open much. The reason is that we didn't do anything directly to the mitral valve. In this particular patient, we did what we've done in a few, which is a mitral valve bypass. So we used a valve conduit from the left atrium to the apex of the ventricle to bypass the calcific mitral stenosis. And here's a postoperative cardiac MR that shows the conduit. Now I'll finish with a discussion of surgery for non-obstructive hypertrophic cardiomyopathy. And the typical patient would be a patient with apical HCM, although there are some other patients that we perform this procedure in. Now, apical hypertrophic cardiomyopathy is more common in Asia. In fact, it may be more common in India than it is in the United States. I'm not sure. It accounts for about 12 to 14% of patients in our clinic, but the incidence may be as high as 25% in Asia. The main problem in these patients is diminished relaxation, in other words, diastolic dysfunction and atrial fibrillation. Now, many patients with apical hypertrophic cardiomyopathy are asymptomatic, but if symptoms develop, they're very difficult to manage because there's really no medications that improve stroke volume or lower end diastolic pressure. What we've done in the past and what we currently do for symptomatic patients who are at the end of their rope and really facing a cardiac transplantation is offer them an apical myectomy to enlarge the ventricle. Here you can see a patient who has a giant left atrium, apical hypertrophic cardiomyopathy, and apical displacement of the papillary muscle. And I'm showing this because for the surgeons, there's really only one technical important issue of the anatomy, and that's that there's often apical displacement of the papillary muscles, and you have to be very careful when you make the initial apical ventriculotomy to avoid injury to the papillary muscle. Now here are the intraoperative photographs of a patient undergoing apical myectomy, and you can see the picture on the right. We've incised the ventricle. There's no apical cavity, and you can see how thick the apex is. Here we've opened it up slightly and are starting to retract and identify the apex, and we enlarge it gradually and end up with something like this on the left, where you can see we've enlarged the cavity here, and then we close the ventricle in this manner. So does the operation work? Well, this is a patient who had a very careful hemodynamic study by Rick Nishimura, both before and after operation. And you can see at the same LV pressure, the patient had a marked reduction in left atrial pressure after apical myectomy. And in aggregate, we did postoperative catheterizations on the first 15 or so patients. In aggregate, there was a reduction in end-diastolic pressure. There was an increase in end-diastolic volume by ventriculography. And there was improvement in their pressure volume curve. Now, as clinicians, we're not used to looking at pressure volume curves, but this is a pressure volume curve that shows the stroke volume and the end-diastolic pressure of a patient with non-obstructive apical hypertrophic cardiomyopathy. And if the operation worked, we would expect an increase in the stroke volume and a decrease in the EDP. This same patient had a study after surgery, and this is the pressure volume curve afterwards. You can see that the EDP is lower and the stroke volume is increased. Now, this is a typical patient who came for evaluation because he was facing a heart transplant. He had apical and midventricular hypertrophic cardiomyopathy, was unresponsive to medical therapy. And here is his preoperative echocardiogram. You can see in the upper left, the long axis, it shows almost no apical chamber. The short axis below, near the papillary muscles, it shows little in the way of a ventricular chamber. And here's a study after surgery. I think you can appreciate that there now is a pumping chamber distally. You can see that in the long axis in the upper left hand. The lower left hand shows enlargement in the transverse cut and a larger LV chamber in a four-chamber view. This patient's stroke volume was now near normal at 72 mLs per beat. Now, we have had experience with almost 200 of these patients, and the operative risk is relatively low. For every patient who's had surgery, the operative risk was 3%, but there have been no deaths after surgery since 2013. But the issue is, what about long-term results and symptomatic relief? Well, this is a survival curve of patients who have non-obstructive apical hypertrophic cardiomyopathy who underwent apical myectomy at our clinic. And you can see the long-term survival. And really the only comparison group that would be useful for these patients are those who have had a transplant or who are listed for transplant, because that really is the only alternate therapy for them. So when we compare the survival of patients that had apical myectomy to those who are waitlisted for transplant, remember, not everybody who gets waitlisted gets a transplant. And so survival of patients who have a myectomy for apical hypertrophic cardiomyopathy is superior to patients who are waitlisted for cardiac transplantation. If you adjust for all the factors that you can adjust for using these two databases, then you see that that difference is even greater. And then if you compare survival of patients who have had a myectomy for apical hypertrophic cardiomyopathy with patients who have hypertrophic cardiomyopathy and receive a transplant, you can see that even though the difference is not statistically significant, there does appear to be superior survival in patients who have had this procedure, apical myectomy. So with apical hypertrophic cardiomyopathy, a few key points. First of all, the apical phenotype is not always benign. Apical myectomy is an option in selected patients with diastolic heart failure and reduced end-diastolic volume. The general numbers that we use are end-diastolic volumes less than 50 mLs per meter squared and stroke volumes less than 30 mLs per meter squared. We've documented that the operation improves diastolic function with an increase in end-diastolic volume and stroke volume and a decrease in end-diastolic pressure. I didn't show you the symptomatic improvement, but we've documented improvement following myectomy to enlarge the ventricle. And the survival appears to be superior to that of patients with hypertrophic cardiomyopathy listed for transplant. So I appreciate, again, the opportunity to speak with you, and I look forward to answering questions during the discussion section. Thank you.
Thank you, Dr. Schaff, for that wonderful lecture. And to the audience, I think we had the pleasure to listen to one of probably the most experienced person in the world today in this particular surgery. So I would be failing in my duty to give you a little bit about Dr. Schaff. So he was had his education from Oklahoma University and did his residency from Hopkins, both general surgery as well as from cardiac surgery. And during his residency, he was awarded the George D. Zudima Award, which was basically his research into ischemic reperfusion injury and diastolic dysfunction. And that paved way for his insights into the apical myectomy surgery that you have recently listened to him, which has taken away many patients from the transplant list. He has been in Mayo Clinic since 1990 and served as the chair between 2001 and 11. By his colleagues, he is considered a top gun, an academic dynamo, and an operating machine. Seamlessly, he will go through 6 ORs in a day. He has an inherent passion and interest in uncommon problems, as you could see in one of his slides, the left atrium to LV conduit. Similarly, he has done apical aortic conduits for calcific or porcelain aortas. He has more than 800 plus publications, 100 book chapters, and 400 presentations.
Go ahead.
And he has a lot of trials and a lot of journal responsibility. He's been in the editorial board for most of the journals. And since the Bari trial, he has been in many trials. He served as the AATS president in 2012 and 2013, and his presidential lecture titled Leadership and Scholarship is a must listen and is available online. An avid golfer, values family and relationships, and I had the great opportunity to work with him. And he blessed us by visiting India in 2017 and was a faculty for our annual live workshop. Ladies and gentlemen, that was Hartzell Schaff who spoke to you on septal myectomy and enlightened us, probably the most experienced surgeon in this area. Thank you very much.
Thank you, Chandra.
Yes, now we'll move on to the next talk. I have the pleasure of introducing Martin Ismarin, who's the director of the Hypertrophic Cardiomyopathy Center at the Tufts University School of Medicine. And he also happens to be the co-director of the Cardiac CT and CMR program and has extensive experience in the management of patients with hypertrophic cardiomyopathy with one of the largest programs of HCM in the United States. Over to you, Martin.
Hi, I'm Marty Marin. I'm very honored to have the opportunity to give you a talk today about sudden death prevention in hypertrophic cardiomyopathy. It's an honor to be talking to you in this dedicated symposium in India on HCM. I want to thank Dr. Hisham Ahmed for the invitation and the opportunity to over the next 20 minutes, really give you an overview on risk stratification in HCM. I thought I'd first start with this introductory slide. Sudden death has been the most visible and feared consequence, as many in the audience know, of HCM for both physicians and patients. And for 20 years, there's been a way to actually prevent these deaths, which is the prophylactic ICD, implantable cardioverter defibrillator. Now, really, the controversy that's emerged is really the best way to identify those HCM patients that are at greatest risk for sudden death and to provide them ICD for primary prevention. And where we stand with that is that there are really now two different strategies, in some way diametrically opposed to each other as far as their structure and strategy. The ACC-AHA is the major individual risk factor strategy and the ESC risk score. I'm going to start today by focusing on the ACC-AHA. It's been around the longest, and in some ways, and I'll try to make this case, perhaps is of the two strategies, the one that gives the best opportunity, or the most reliable opportunity to develop, to identify the highest risk patients deserving, as I said, of ICD therapy. And here it is. We have relied on a number of non-invasive major risk markers over the years to identify high-risk patients with HCM. And family history of HCM, sudden death, meaning sudden death in a close relative HCM, unexplained syncope. By clinical history, you've excluded neurocardiogenic and vasovagal etiology. And that's syncope that in general has occurred somewhat close to the time that you are evaluating the HCM patient. More remote or distant syncope really has less predictive value as a risk marker for sudden death. Multiple repetitive non-sustained V on ambulatory monitoring, that's generally been 24 to 48 hours of continuous monitoring, and massive left ventricular hypertrophy of 30 millimeters or more anywhere in the LV chamber. Now, perhaps one of the really important strengths, I should say, of the ACC-AHA risk factor strategy is that it's flexible. And that flexibility allows the opportunity to incorporate novel risk markers as they emerge with data to support them as predictors for sudden death events in HCM. And that, in fact, has happened over the last 5 to 10 years in HCM. And those three novel risk markers include HCM patients with LV apical aneurysm, extensive scarring in the myocardium, or LGE, late gallium enhancement, identified by contrast-enhanced MRI, and end-stage HCM, where the systolic function decreases to 50%, less than 50%. These three new markers, I'm going to touch on in a minute specifically, but along with the established risk markers that I just mentioned, really together define an enhanced ACC-AHA individual risk marker strategy, for which essentially one or more of these major risk markers in a young or middle-aged patient with HCM may be enough to consider that patient's risk increased, where it would be reasonable to consider that patient for primary prevention ICD therapy. In addition, this strategy allows the opportunity, of course, for physician judgment when risk stratifying patients. So important in a genetic heart disease like HCM, which is so heterogeneous in its phenotypic expression and in some ways natural history. And specifically what I mean is, for example, greater weight can often be given in an individual patient, for example, who has multiple runs of NSVT, or one long run of NSVT, or perhaps several very fast runs of NSVT, as associated with greater risk for future sudden death than, for example, one short, slow, isolated run of non-sustained VT. And of course, this strategy also provides the chance to incorporate the wishes of the patient after they become fully informed about what their risk for sudden death may be, as well as the strengths and limitations of ICD therapy, particularly long-term ICD device therapy, since these are often young patients, and allows that patient to be fully educated, informed, and empowered to make the best decision about device therapy for them. The so-called shared decision-making strategy, which is always helpful to incorporate in these often very challenging, complex ICD decision-making situations in HCM. let me touch on the new markers just for a minute. And here's late gadolinium enhancement or scarring in the myocardium. This is contrast-enhanced MRI where there's intravenous injection of gadolinium. Gadolinium is, of course, taken up into areas of the myocardium, which in HCM we consider to represent scar or fibrosis. And they're bright. The arrows point to those areas. Late gadolinium enhancement, LGE, equals fibrosis. You can see the number of different patients here with HCM. Location, pattern, and distribution of LG is very diverse. Point is that you can not only see the scar, but you could quantify it as a total amount or as a percent of the LV mass. About 60% of patients with HCM will have evidence of late gadolinium enhancement. About 40% imaged by this technique show no scar or no LG by MRI. And what we know about this this imaging marker, LG, is that in HCM, through a number of prospective studies, has been associated with an increased risk for sudden death events. Here's one of the largest of those studies. This is an international multi-center study over close to 1,300 HCM patients scanned by contrast-enhanced MR and then followed for several years for the outcome of sudden death event, which is sudden death, appropriate ICD shock for VT or VF for an ICD that went in after the MRI or out of hospital cardiac arrest. And you can see a very strong relationship between increasing amount of scar in HCM or LG and increased risk for sudden death events, where extensive scarring is associated with a twofold greater risk for sudden death compared to an HCM patient who has no scar or LG negative. And in fact, LG negative or no scar is a reassuring finding associated with low risk. Patients often like to hear as well that they had no scar in their heart by MRI as well. It's a reassuring finding. And the relationship between LG or scar and outcome sudden death events is independent of other variables that can impact risk too, including the other risk factors, age, ejection fraction, gender, mass, and left ventricular alpha tract obstruction. And so it essentially represents a very strong independent risk marker for future sudden death events. Now, switching to another of the newer enhanced risk factors is the HCM patients with LV apical aneurysms. These are HCM patients that develop thinning of the apex. It's often akinetic or dyskinetic segment. It often takes up gadolinium, and so it is a transmural area of scar. These form probably because of high LV apical systolic pressures, which are present in these patients due to mid-cavitary obstruction from the septum and lateral wall coming together in mid-systole. The adverse remodeling that's promoted by that mid-cavitary obstruction is probably what's responsible for ultimately the formation of wall thinning and the scar, the apex. Now, the scarred apex, in fact, does provide another structural nidus for ventricular tachycardia, which often originates at the juncture of the aneurysm rim and myocardium, and also provides a nidus for stasis of blood, clot formation, and the risk for thromboembolic events. And the point is that the HCM patients with apical aneurysms really, for those structurally abnormal reasons that I just explained, are at increased risk for both sudden death and stroke. Here is a contemporary look at the HCM patients with LV apical aneurysms, about 100 of them followed for several years. They are represented by the blue bars, and HCM patients without an LV apical aneurysm by the red bars. And you can see almost a 5-fold greater increased risk in sudden death events if you've got an aneurysm in HCM versus if you do not. Increased risk as well of heart failure events and also, as I said, stroke. And really for that reason, identifying HCM patients with LV apical aneurysms is really important because it directly impacts the recommendations regarding management. And in that regard, sometimes these apical aneurysms can be missed with echocardiography, particularly if no LV opacification or contrast is used. Obviously, by using a LV contrast, you can enhance detection of the apical aneurysms, and of course, if you're using MRI, very reliable at imaging the distal portion of the LV chamber and seeing these aneurysms, as well as the opportunity to image the scar and possibility of a clot as well. Really, for this reason, another reason I should say that we use MRI on all patients initially to best define their phenotype. Now, as I said, increased risk for sudden death events and stroke in this high-risk phenotypic subgroup of HCM patients with apical aneurysms. We often will recommend primary prevention for these patients based on the presence almost solely of an aneurysm that's scarred, and we'll recommend, of course, anticoagulation. I will mention that this is really a subgroup, though, where if there is recurrent ventricular tachycardia causing repetitive or multiple ICD shocks, these VT can be treated actually with ablation. It's the only subgroup of HCM patients where VT ablation is applicable because the focus for VT in these patients really arises from a specific location, usually at the juncture of the aneurysm rim and myocardium, and that can be addressed through endo or epicardial focal radiofrequency ablation to either mitigate or, in some cases, I said, eliminate future VT. So that's another thing to keep in mind if a patient like that arises for you. The other high-risk subgroup are those patients that develop over time adverse LV remodeling that's due to progressive scarring in the myocardium that causes ultimately a process of wall thinning and cavity dilatation, and ultimately as well, in lots of patients, systolic dysfunction where the EF will drop below 50%. This is the end stage or burned out phase of HCM. It is ultimately defined by the metric of ejection fraction. As you know, most patients with HCM reside with hyperdynamic function, EFs of 60, 65, 70%. So less than 50% is really a significant relative decrease in systolic function in this disease. And here is a contemporary look at the end-stage patients by Ethan Rowan and our group. End-stage patients represented again in the blue bars, HCM patients with normal or preserved systolic function in red, and you can see substantial increased risk in sudden death events. This is probably related to the fact that there is so much extensive fibrosis and scarring as part of the end stage that it provides, again, substantially diffuse abnormal substrate and focus for ventricular tachyarrhythmias, and also increased risk in these patients of progressive heart failure and often the need for advanced heart failure therapy like transplant that often occurs at a relatively young age, since these patients are often usually about midlife when they develop the end stage phase. And so it's very appropriate for the fact that they are at increased risk for sudden death, and also to help bridge them to more definitive heart failure treatment, to consider primary prevention ICD therapy for the end stage HCM patients. So here's the, again, the enhanced ACC-HA risk factor strategy that I've been talking about. Question is, how effective really is it? And we looked at that recently over a single center U.S. experience at the Tufts HCM Center over a 17-year period with over 2,000 consecutive patients followed for about 5 years. You can see the number that had primary prevention devices placed because they had one or more of those major risk markers with an average age of about 51. And this is what happened. We had, over that period of time, 82 patients that we considered to have had their lives saved because of that strategy. The device was put in, again, for primary prevention because of one or more of those risk markers that ultimately delivered a potentially life-saving shock for fast VT or VF. And those 82 patients that were saved exceeded by almost 50-fold the number of HCM patients over that period of time that died suddenly, which was very small at 5, 2 of which were offered devices because they had one or more of the risk markers but declined, 2 no risk factor patients, and 1 was not advised. And so this data really does support the idea or principle that this enhanced risk marker strategy, along with shared decision making and good clinical judgment like we've talked about, you're able to really identify nearly all at-risk HCM patients, and it does underscore the principle that sudden death prevention in HCM is now really a reality. The European Society of Cardiology, in their last guideline several years ago, promoted a different way of approaching risk stratification with an ESC risk score. And what this is a logistic regression equation, essentially, in which you impute into the formula a number of different clinical variables, and then it then tells you, the formula, what your patient's 5-year sudden death risk is. It provides that into three different categories: low risk, based on a 5-year risk of sudden death of less than 4%, intermediate risk, or high risk. And depending on which of these three categories the patient's risk is, it then will assign a recommendation for management. ICDs not indicated for low-risk patients may be considered for intermediate and should be considered for high risk. Now, the question really is, how does this strategy, this ESC risk score, compare to what I just showed you for the ACC-AHA major risk factor model? And I think one of the easiest ways to try to understand that is with sensitivity and specificity. And sensitivity, which of course is a statistical term, refers to the ability of the model to identify those patients who have sudden death events. So preventing sudden death is how we look at sensitivity here for these two risk models. And so what we did is we took the Tufts cohort, and we, who were all managed using the ACC-AHA risk factor strategies I showed you, we went back retrospectively, and we applied the ESC risk score at the time that ICD decision-making was being made to determine outcome. And what we found was that the sensitivity of the ACC-AHA was 95%, much higher than the sensitivity of the ESC risk score for predicting those patients who went on to have sudden death events. And this, sort of relatively low sensitivity of the ESC risk score was not only related to this one large US single center study, but there have been numerous studies over the years looking at the ESC risk score in different patient populations in different geographic locations. You can see them here, different cohort sizes, different number of sudden death events within these studies. Here's the sudden death events in those patients that had ESC risk scores that were low or intermediate. And here's ultimately the sensitivity of the ESC risk score in these populations for, again, predicting those patients who went on to have sudden death events. You can see a range of sensitivities here, although the average, again, for these studies was about 34%, which, again, much lower than the sensitivity of the ACC-AHA. And this low sensitivity difference between the two models is important because it goes to the issue of the fact that low sensitivity means many high-risk HCM patients would remain unprotected from sudden death without device therapy. And so one question is, so wait a minute, so why is the sensitivity of the ESC, so much lower than the ACC-AHA? And here's one look at that. And if you look at the top of this slide, what's important is to recognize what is missing from the ESC risk model. And of course, it's not the fault of the ESC risk score that these three important new markers are not incorporated. The model, the ESC risk model, was developed, at least at the beginning, largely before these risk markers emerged with enough data to support them as associated with increased risk for sudden death. And that includes what I've been talking about, the CMR. There's no CMR at all in the ESC risk score. So scarring is not part of that model. The very high risk LV aneurysms are not in the ESC risk score, and ejection fraction as a variable is not included either. And that's important because these three novel major risk markers now really represent about 20% of all appropriate primary prevention ICD shocks for VT/VF are in patients that have these new risk markers. The ESC also has questionable additions to it. LA size, outflow gradient, and remote syncope have had sort of questionable relationships to each of them to being a marker for future risk of sudden death. ESC is also more restrictive in some ways than the ACC-AHA with respect to decision making because the risk score gives a definitive treatment recommendation. No ICD, yes ICD, and therefore moves a little bit farther away from physician judgment because it's more of an automated decision-making tool. And as well, the ESC risk score has not yet been validated prospectively in an independent HCM population. It's always been retrospectively applied. And so we don't really know how well it works prospectively in individual patient decision-making situations. Now, there is, of course, some cost to higher sensitivity, and that would be specificity, which, of course, is the ability to detect patients that are not at risk for sudden death. And in that regard, the ESC risk score has a specificity that is higher, a little bit, than the ACC-AHA. That may mean that you may have the opportunity to avoid implanting some ICDs that are unnecessary, meaning they don't ever go off or shock a patient, using the ESC versus the ACC-AHA strategy. Although I will point out that for all the number needed to treat for both strategies is statistically similar. What that means is that the number of ICDs that are implanted that ultimately do shock for VT or VF is the same, whether it's the ACC or the ESC. So I'll conclude really with these points here, that the ACC-AHA major risk factor strategy provides the opportunity, because of how it's structured, to incorporate physician judgment and shared decision-making, along with flexibility to incorporate new risk markers in HCM. Those include now LV apical aneurysms, extensive scarring, and systolic dysfunction. In addition, the ACC also is associated with higher sensitivity compared to ESC for predicting sudden death events in HCM patients, and therefore the opportunity to identify nearly all at-risk HCM patients with this strategy and to provide them prophylactic ICD treatment. The cost of this greater sensitivity is some degree of overtreatment, meaning the specificity, but the number needed to treat is equal. Again, I'll say that, because we, personally, no risk factor strategy is ever going to be 100% perfect in this disease. It's just likely an unachievable goal. Ultimately, you have to resolve yourself to deciding about whether you prefer a strategy with more sensitivity or more specificity. Personally, I want to side on the side of higher sensitivity, protecting more patients against sudden death than and I'll accept some degree of overtreatment for that. And I'm okay with that. That's really, I think, what this comes down to. And I want to thank you, and it's for that reason, by the way, that we really solely use the ACC-AHA risk factor strategy in assessing patients at the Tufts HCM Center. I want to thank you again for your time. Appreciate it, and I'm happy, of course, to answer any questions that may come up. Thank you.
Thank you, Dr. Marin, for this very interesting session on risk stratification for certain cardiac death. Of course, it's always a problem when we are looking at these patients. Now, since you have to leave early, we'd like to ask you the first question of this session. And particularly, it has been asked by a number of people, is there a role of risk stratification for sudden cardiac death after a successful surgical myectomy? Am I audible? Hello?
Yes, you are audible.
Yeah, thank you. I asked this question from Dr. Marin. Is there a role of risk stratification after a successful surgical myectomy? And if so, are the same risk markers applicable?
Dr. Maron is not available. We can ask Dr. Schaff because he has a large experience. I don't think Dr. Maron is able to respond.
Okay, anyone?
Martin?
Can you hear me?
Yes.
Okay, this is Barry Maron. I'm not sure what happened with the technology. I can try to answer that question though, if you want.
Yes, please.
Go ahead.
The heart failure pathway with obstruction leading to myectomy is separate from the pathway that you just heard about, which is sudden death, risk, and prevention with ICD. So while there is some evidence that normalizing left ventricular pressures with myectomy may decrease arrhythmogenicity, the real answer is that a patient who has refractory heart failure and needs myectomy, who also independently has risk markers for sudden death, as you just heard about, could be a candidate for an ICD. And of course, Dr. Schaff and his colleagues at Mayo have operated on a number of patients and then thereafter placed an ICD for primary prevention because of the risk markers that are independent of the obstruction. Bishop? Hello?
Hello.
Audible.
Audible. So actually that brings us to the question, is there a relationship between the presence of obstruction and the risk of sudden cardiac death? And when these patients reach a dilated stage with ejection fraction falling below 50% and go into heart failure, most of the times the obstruction also becomes significantly less. In some people, it may even disappear.
Okay, well, those are two different things to me. The first issue is that in the presence of preserved systolic function, which is the usual situation, is obstruction, let's say even marked rest obstruction, a risk marker for sudden death. And it turns out to be a very weak one, for sure. Yeah. And we do not implant ICDs based totally or largely on the basis of the presence of a gradient. So ICDs for gradient is not a practice. And patients convert into the so-called end stage with systolic dysfunction, then those are patients that are candidates based on that for a primary prevention ICD because they're becoming transplant candidates. Patients that go on the list for heart transplant, wherever they may be on the list in terms of priority, are candidates for an ICD.
Dr. Maron, in your experience of a very long follow-up of these patients after surgical myectomy, have you seen any alteration in their risk of sudden cardiac death? I mean, what has been the experience in that?
Okay, say that again, the relationship between risk of sudden cardiac death and what?
After successful surgical myectomy, the patient becomes less symptomatic and most of them have good ejection fractions, when they have the obstructive stage. So have you seen?
Well, the answer to that is that the Mayo Clinic investigators have presented data that suggests that relief of the gradient and therefore normalization of left ventricular pressures seems to have some decrease in terms of arrhythmogenicity and therefore potentially the risk of sudden cardiac death. But operation is not a procedure per se to lower risk or prevent sudden death. That's the job of the implantable defibrillator.
Thank you.
Dr. Shah, are you here? Dr. Chandra here. So due to paucity of time, we will restrict to a couple of questions and move forward. Dr. Shah?
Sure.
Can you hear? So the question I want to ask you is, at the Mayo Clinic, you said you had presented the data that with excellent results in terms of residual gradients, which had an impact on the long-term outcome. You had an excellent echo setup, which can tell you at the end of the operation whether your myectomy is complete and the gradient is perfect. The problem is many a times when you come off CPB, the gradients can be variable due to the hemodynamic status of the patient. And what is the how will you decide whether to go back in? And if so, when you add a apical approach, if it is some mid-cavity component of the myectomy is also present?
Sure. Well, we would expect the gradient to be, at least at rest, less than 15 to 20 for sure, and with provocation, less than 20. It depends a little bit on what the patient's gradient was before myectomy. And it also depends on the presence or absence of SAM. There'll be a few patients in whom you can have an adequate subaortic myectomy, you eliminate SAM, or you have only residual chordal SAM, and then there's a 30 or 40 millimeter gradient that the cardiologist is not certain whether it's in the outflow tract or the mid-ventricle. So I think if you have a gradient, the thing to look for is whether there's SAM and residual contact lesion. If there's SAM and a residual contact lesion, then what you do is ask yourself the question, can I reach that through the aorta again, or should I go through the apex? And it's something that only the surgeon can decide at the time of the operation.
And we quickly add on the slide you mentioned about the gender difference in long-term outcomes in terms of survival between males and females in your presentation.
This is something that comes up in almost every analysis, both in natural history studies and in post-operative studies. It's not clear why this is. There's some suspicion that women get to surgery later, although that begs the question of whether surgery really improves the outcome. But the women may come to operation at a later stage in the disease. It's unclear to us exactly why that is. Maybe Barry has some ideas.
I think to the question that was asked, would you like to address that question, Dr. Shah, that was asked to Barry earlier about the risk of sudden death when does it come down after septal myectomy?
No, I think obviously he is the expert in this area, and I think that reflects our practice. We make the decision, or the cardiologists make the recommendation with the patient on whether to implant an ICD before surgery. So that decision is made regardless of the outcome of the operation. We don't put the defibrillators in during surgery. That's done on the second or third day after the procedure. Now, the only patients where the gradient may be an issue, and this is a point of discussion, if you have somebody who is very high risk, a young patient, for example, who's very high risk, has a strong family history of sudden cardiac death, and has a gradient of 80, and you're saying what is the best chance of reducing that patient's risk of sudden cardiac death, is obviously a defibrillator, but I think you should also consider relieving the outflow tract gradient. So we agree that it's not the strongest risk factor for sudden cardiac death, but there are some subgroups where it does impact our decision making.
Thank you, Dr. Schaff. I think just for the paucity of time, we'll probably just move on to the next session, if that's okay.
Thank you.
Thank you.
Yes, thank you.
Thank you, Dr. Schaff. Thanks for being there.
Thanks.
So we come to the final session of the day. Today, it's the keynote lecture session, and it's chaired by two eminent faculty, Dr. K. Venugopal, the current professor and head of Department of Cardiology at the Pushpagiri Institute of Medical Sciences in Cochin, Kerala, and Dr. K.K. Talwar, who's director and professor head of the Department of Cardiology at the Max Super Specialty Hospital in Mohali, and the former director of PGI Chandigarh. So I'll give it over to Dr. K. Venugopal.
Yeah, it's my proud privilege to introduce Dr. Professor Maran to you. I don't think anybody who studies hypertrophic cardiomyopathy will be unfamiliar with the name of Dr. Barry J. Maran, who has been in the field of hypertrophic cardiomyopathy for the last 3 decades. As we are having shortage of time, I think we'll not waste much time. We'll straight away go to the keynote lecture, and then we'll have quite some time for discussion, questions and answers at the end of session. Dr. Talwar, anything to add? Dr. Talwar? Okay, can we go to Dr. Maran's talk, please?
Hello. It's my pleasure to speak to all of you, Indian cardiologists, about hypertrophic cardiomyopathy, a disease that I've been involved with for quite a while, as you may know. I'm going to try to place HCM into a modern context so that what you may remember from medical school or a long time ago may no longer be operative. There's been quite a bit of progress in what this disease is and, of course, the outcome, clinical outcome that can be expected. First point to make is that this is a global disease. It has been found in at least 122 countries on all continents, encompassing 90% of the world's population. It's HCM is really everywhere, which is something that perhaps is surprising to all of you. The most common inherited cardiac disease, perhaps. As a global disease, we have prevalence estimates that are, I think, reasonable. They say that HCM is occurring in the general population about 1 in 200 to 1 in 500. That would mean that extrapolated to the United States, at least, that would be 750 Americans affected by HCM, and worldwide could be as many as 20 million or more individuals. On the other hand, only a fraction appear to be identified. Our number here in the United States is about 100,000, so you can see that it is probably almost 10 times more common than it is a identified clinical disease in practice. And that means that we are all seeing really the tip of the iceberg. That's independent of whether you're in private practice or in a major center, such as exist now in southern India, but North America for many years. So what the disease is to us is what we get to see of it, with many of its manifestations underground. But we have painstakingly described HCM in clinical practice. This is what it appears to be in the Tufts Boston cohort, for example, which is a tertiary center, of course. About half our patients are really asymptomatic or stable and probably going to experience normal longevity without any need for major interventions in terms of management. On the other hand, the other half are patients with complications that require dressing with management considerations. The most common of those turns out to be heart failure, exertional dyspnea with or without chest pain. Atrial fibrillation is the most common arrhythmia in this disease, sustained arrhythmia. And the arrhythmic sudden death risk is the least common of these complications, interestingly enough, even though its visibility has been the highest through the years. So let's talk about atrial fibrillation. Let's talk about sudden death, specifically this disease. Now, its visibility had been enhanced several years ago when it was determined that HCM was the most common cause of sudden death in competitive athletes. Again, highly visible issue. HCM is responsible for about 1/3 of these athletic field deaths. And as a result, there are recommendations over the last 25 years that support the idea that it makes sense to disqualify patients with HCM from competitive sports to make the athletic field safer and reduce their risk. So now, translating this back into the cohort patients, the patients that we see, in-hospital patients, because the sudden death in athletes is a community-based issue, because those athletes have not been evaluated or diagnosed prior to their event for the most part. But our patients are subject to our evaluation, and the first order in that regard is to determine whether there's a risk for sudden cardiac death. And each patient initially has a risk stratification looking for these major risk factors that you see in the upper left. Family history of HCM-related sudden death, unexplained syncope, multiple repetitive NSVT on ambulatory monitoring, extensive LGE or fibrosis that will be addressed by Martin Maron, the left ventricular apical aneurysms that will come up in those discussions. I thought I would just show one risk marker as this part of the discussion. Others will talk about the others in much more detail. But massive hypertrophy is a risk marker. The septal thickness can be up to 40, even more millimeters. This is an example of that. There isn't any other disease that alters left ventricular mass quite like this in some instances. So the massive hypertrophy has become a risk marker based on data like these, which shows a linear relationship between risk for sudden death and left ventricular wall thickness by echocardiography. On the left are patients with mild wall thickening for whom everything equal risk is lower. On the right are the patients with extreme hypertrophy, and our data would say that 30 millimeters or more would qualify a patient as a higher risk and a candidate for an implantable defibrillator based solely on the morphologic findings. Now, the good news is that there is a anti-risk factor, if you like, being age itself, because we have found very low risk for arrhythmic sudden death events in patients over the age of 60, 65. Talking about stable patients who are being evaluated on a regular basis. And this low risk shown to the right supports the idea of resistance, if you like, to implanting patients at advanced age for primary prevention with implantable defibrillators. We uncommonly implant patients prophylactically, even in the presence of risk markers when they have achieved ages of 60, 65, and 70. So that takes us to a discussion about prevention of sudden death in HCM. That's a big concept, actually. I can certainly remember when we had no way of anticipating or preventing these catastrophes in young patients. And this is our registry, which is developed for high-risk patients with ICDs to determine the efficacy of the implantable devices for terminating VT-VF and preventing sudden death in these patients. And the 4% per year for primary prevention patients is quite high, of course, and substantiates this risk that the disease harbors and has been the most visible complication of HCM. This is our prospective evaluation that I'm sure Dr. Marin has discussed with you in detail, but very simply, prospectively evaluating patients for sudden death risk using only the standard risk markers. It's a clinical risk marker strategy. Not statistical, not mathematical, just clinical practice approach to this problem of predicting which patients will have events. And remarkably, the sensitivity for that approach was 95%, and you can see the bar on the left is 82 patients who were selected for ICDs and had their VT-VF aborted. Compared to the right, patients not implanted with devices who, for a variety of reasons, did die suddenly. And one of those reasons was 2 out of the 5 patients that you see there actually declined the ICD with their risk factors. So the ICD has changed this disease. And the related point is that after the life-saving interventions from the ICD, not much happens, at least in terms of sudden death events or hospitalizations for heart failure. All of those complications coming after device interventions are common in ischemic heart disease that you see to the right. With MATID2 used an example, 20 to 30% of patients with sudden death or hospitalizations for heart failure. On the left, HCM, which can be regarded as the ICD strategy could be regarded as life-saving rather than life-prolonging in young people. The decisions that I'm talking about are not always simple by any means. There is very frequently an ambiguous gray zone that we have to deal with, and the way we do that is employ transparency, full disclosure, and patient autonomy. What that means is that we use it when we don't know, and when there is gray and ambiguity, we practice what has been called shared decision-making. In other words, an interactive decision-making process with the patient who is fully informed. Now, I've gotten this far without talking about genetics. There are, of course, 11 genes that have been identified as with mutations that are regarded as disease-causing in HCM. But how do you use that information? In other words, what do you do with commercial genetic testing, which can identify these mutations, of which there are now thousands? many of which regarded as disease-causing. Well, the answer to that is that the genetic testing does not generate data that can aid in assessing prognosis or predicting the future clinical course of any patient, including sudden death. Furthermore, if your patient has left ventricular hypertrophy and a clear-cut diagnosis of HCM, then genetic testing will not add anything to the evaluation. There are family members, however, who do not have left ventricular hypertrophy on imaging and can be affected genetically. This is the group called genotype positive, phenotype negative. Those individuals can, in some cases, evolve to left ventricular hypertrophy and the phenotype of HCM. But this is relatively uncommon, and events are decidedly rare in this group, even unheard of at this time. So we've been talking and using genetic testing in HCM. I just wanted to make this point because I think it's important. While genetic testing is useful for family screening, the genetic model, sarcomere mutation hypothesis, has not really made any difference or any inroads into predicting sudden death in this patient population. That's a disappointment, but that's a reality. On the other hand, I want to emphasize and even underscore that just about all the data that I'm showing that has changed this disease comes from clinical practice and clinical research. So molecular biology is important, but it has very little to do with our practices of HCM. So taking a look at what's happened, the number of sudden deaths due to this disease have decreased. There's no question about that with the implantable defibrillator. And the void is, if you like, being taken up by increasing attention placed to heart failure, symptoms of heart failure, even advanced heart failure. And when we talk about that part of this disease, we're talking about left ventricular outflow tract obstruction, largely, because the vast majority of patients with heart failure, meaning exertional dyspnea with or without chest pain, are in that clinical situation because of outflow tract gradients. And that brings us to the surgical myectomy, which is the gold standard to reverse heart failure in HCM. This is a reversible form of heart failure. And that is evidenced by this slide, which are data from the Mayo Clinic series, and show that in terms of total mortality, over a long period of time, survival was the same, essentially, in patients who had had myectomy as you would find in the general population. So the total mortality, or all-cause mortality, did not differ at 83%. In addition, operative mortality, meaning surgical myectomy, has itself decreased to far less than 1%, as long as we are including the experience of the elite and practiced myectomy surgeons at the major dedicated centers. So what you have is a low risk but high benefit procedure. That's what surgical myectomy has become. With most of the mortality left in this disease, residing in the non-obstructive HCM subpopulation. Patients without gradients who can develop progressive heart failure and leading, as I'll show you, in some cases to transplant. So that is where we have evolved to where progressive heart failure is the most visible consequence of this disease at this time, or the less treated, most visible consequence. And in some instances, transplant does represent the only definitive intervention for these patients who are refractory to all other treatments. At Tufts, our 5-year survival with transplant is actually more than 90%. This is a viable treatment for desperate patients, and survival post-transplant in hypertrophic cardiomyopathy is actually somewhat greater than it is with other ischemic or non-ischemic cardiomyopathies that come to transplant. So it's time in this talk to try to put all this together. There's been a lot of work in a lot of strategies and approaches. But if you took a single well-defined cohort, like the Tufts cohort, which is at this time about 2,500 patients, the question is, what is possible and what is the role of these dedicated centers in treating this disease and decreasing mortality? Now, well, there are a number of ways to show this. This is the way I like to do it. If we say that historic mortality is somewhere around 3% per year, it's been cited as higher than that. But in our current clinical situation, if we take the ICD and add it to the mix, and that will drop that mortality to 0.8%. And if we add the transplants for refractory heart failure, that will drop the mortality to 0.6, and then furthermore, other modalities, or let's say out-of-hospital cardiac arrest and therapeutic hypothermia, bring us to that 0.5% per year. That really is the achievable mortality rate for hypertrophic cardiomyopathy. And it turns out that that number is very consistent across the ages of patients, including those that are children and young adults, who in some regards have the highest risk profile with HCM. In fact, remarkably, if we examine the Tufts cohort that I've been talking to you about, because of these treatments, okay, we can say that there have been more than 160 lives actually saved. A lot of that is the ICD, but not all of it. So it's possible at this point to say that HCM is now a contemporary disease. It's treatable, and those treatments are compatible with low mortality, low morbidity, and even extended, if not normal, longevity. All that is possible in 2020 because the interventions I'm talking about are such that they, in fact, change the clinical course of the disease. This is a fundamental change. So I've been doing this, obviously, for a long time, so I can reflect perhaps better than most on this progress that I've been talking about. We started with mortality rates that were like 6% per year, which is extraordinarily high if you extrapolate it out, and have gone through different phases to where we're now at this 0.5% per year, based on usage, introduction of the implantable defibrillator, low risk, high benefit surgical myectomy, which in the old days used to be much higher risk, and all the innovations in defibrillation. This is where we are now, and it is a different story than the past. So I can take that original slide that I showed and put treatments underneath each of the bulbs that have made a difference. The atrial fibrillation, which I haven't had a chance to talk about in any detail, is accompanied by drugs, antiarrhythmics, and anticoagulation, which has been made much simpler. Catheter ablation, the Mays procedure, it can be performed with surgical myectomy. All of that has decimated the risk of stroke and diminished the frequency of atrial fibrillation. Over to the left, progressive heart failure and obstructive HCM. And of course, there are drugs. There will be more drugs. There is the surgical septal myectomy and its alternative alcohol ablation, which can obliterate and does in fact abolish the alpha tract gradient and reverse heart failure. Patients with non-obstructive HCM have lesser options when they become refractory and progressive, but the most definitive remains heart transplant. And then over to the far left is the sudden death risk, which we started with as the most visible and feared complication of the disease that had no treatment, but there is a treatment now. The primary prevention is possible, it's effective, and the defibrillator does work in HCM, so that the number of sudden deaths has diminished substantially. Thank you very much.
Thank you very much, Professor Maran, for this masterly address. I think because of limited... Hello? Yes. We will have one or two questions only. I think I'd like to ask you, Professor Maran, that you mentioned that genetic testing is just more of a presently theoretical interest, but do you think there is a scope for this precision therapy in the future? Professor Maran?
You need to unmute yourself, Professor Maran. You need to unmute yourself. You're muted, Professor Maran.
Yeah, now he's unmuted.
I got it.
Precision therapy.
Yeah. I'm sorry. Which therapy are you asking about?
Talked about that precision therapy, like genetic sort of interventions, because there is some data at the basic level that this therapy in future may be useful to sort of when there are mutations to handle those by genetic interventions. Do you think there is a sort of what is the kind of a future of this kind of therapy?
So you're asking, is there a future for gene therapy?
Yeah, exactly.
Precision therapy.
Precision.
But that's
gene-specific therapy.
Gene editing then, right? You know, I guess anything's possible, but there's so many issues and problems with that kind of approach that I think that you know, we're always looking for something better. But, you know, it's also hard sometimes to realize when you have reached a fairly high level in management and therapy as I described. There can always be unmet needs and something better. They may come at a cost, and they may be a fantasy, which I think gene editing is. But so one of the points I wanted to make here today was that there has been rather significant progress in this disease that has lowered mortality and morbidity. This was the idea. And not that we shouldn't look around for other things, but we should also recognize that what we have now represents something very, very substantial. After all, the mortality associated with HCM now is the lowest of any disease. Any disease-related mortality is higher than HCM. It's the bottom of the list rather than the top.
Professor Talwar, there was a successful gene editing in cardiomyopathy, but we'll have to wait and see was there any.
No, that's right. I mean, I just thought, what is the future kind of? There are some kind of. I'm sure you, in the field, sort of will be knowing more. But that seems to be an interesting area. But I think you're right. There are some limitations still.
Well, there are major limitations. Those ideas. And, one of the limitations to gene editing is that you really would have to be sure that the gene that you're editing was causing the disease. And that has become a much more complicated issue based on a lot of experience with genetic testing in this disease.
Has there been any new pharmacological approaches to preventing the heart failure development? You had trials with mavacamten, which are not very good. Is there any new approaches, pharmacological approaches that you're planning?
Well, I mean, that's the major unmet need that you're talking about. Is there a drug that can be offered patients with non-obstructive disease,
yes,
even to prevent those relatively few patients that progress to heart transplant? I mean, that's really the area of most need. Negative inotropes like mavacamten, and there are others in process, do not seem to be relevant to non-obstructive HCM. They've already had a phase 2 trial that was not successful in non-obstructive disease. That, I think you're right. That's the big area. But even at that, the number of patients that progress with their disease to heart transplant, which is something we would prefer not to happen, is very small. It's 1% of the overall HCM population. But so despite the progress, which I think we should not try to overlook because of something glitzy down the road, possibly, there are unmet needs in the disease. We have to decide what those are. And while mavacamten will be, I guess, useful as an additional drug for obstructive disease, we've already had one that's still around called disopyramide that is virtually identical to mavacamten. So there's a lot of hype about new stuff in HCM. And I don't think that's necessarily bad, but we have to be prudent.
There's one question regarding the current status of disopyramide. There's a question. What's the current status of disopyramide use in hypertrophic cardiomyopathy? I think very few people use it now. Earlier, we used to use it much more frequently. I don't know what's the experience of most of us.
This is still a good drug. I think let us hear from him, but availability is an issue with us.
Yes, I think so.
Yeah, well, that's an issue. And so, I think that mavacamten, if it ever gets approved, which by the way, it is not at this time, will There's still a vacuum. You can't even get disopyramide. There's no reason to argue which one is better. Okay. I think the mavacamten is, by the way, a much stronger negative inotrope, and with that comes the risk for excessive systolic dysfunction. As the drug is lowering the gradient, it is, by reducing contractility, also reducing, in some cases, the ejection fraction, potentially leading to heart failure. So disopyramide does not have that history, as far as we can tell. I think it's still an important option as a negative inotrope, if you can get it.
Yes.
Well, I think because of a paucity of time, I got a message from Dr. Narasimhan that we'll have to close the session. And I think let us all give a big hand to Professor Maron for this masterly address. And I think he has been always a treat to listen on this particular disease aspect because of his, I think, probably the largest experience that he has. Thank you so much, Professor Maron, for your sort of masterly lecture and deliberation to us. Thank you.
You're welcome. Thank you.
Thank you, Dr. Maron. Now I'll just invite Dr. Samir Srivastava to just briefly give the concluding remarks for the day. Dr. Srivastava, over to you.
Thank you for giving me this opportunity. First of all those people who have sat through the evening, they will not disagree with me that it was an absolutely ecstatic academic bonanza. There's nothing short of that. So it all started with our dear friend Ramakrishnan setting up the stage to start the day. And Neha showed some very, very beautiful pictures of echo and multi-modality imaging, followed by Lorenzo, who basically talked. Most of us are rather ignorant about the genetics in hypertrophic cardiomyopathy, and he educated us. It was indeed a very, very educative session. And then our own Hisham showed some hypertrophic mimics. After that, we went on to see some different modalities of treatment, which was described by Muthaiya, and septal myomectomy. The man is a legend in his own terms as far as surgery of this is concerned. And well, last session was that of Martin Mudd. The two Marons came back to back, one talking about sudden cardiac death. The last was Barry Jamel. So it was not only a pleasure, but it was an honor to have heard both the Marons speak. And I must say that it was a wonderful session, and hope to join tomorrow also. And I'm sure all of you must have enjoyed the same. Hashim is talking to his girlfriends.
No, Hisham,
sorry.
We call Hashim even on to listen to you.
Okay. So if Dr. Narasimhan is here.
Yes. Go ahead, please. Thank you, Samir.
Close the session and then we join.
Yeah, wonderful. I think it was a wonderful session. More importantly, globally, I would like to thank the leaders in this field. For example, the natural history study that Dr. Maron has presented, how it has helped all over the globe to practice more a rational medicine and take care of these patients with hypertrophic cardiomyopathy. And the fantastic lecture by Dr. Schaff. And my only appeal is to kind of get the younger surgeons on board and try to get the same kind of results, at least in the rest of the globe. That's a task, huge task that we ask of Dr. Schaff. I hope that there is some kind of a video training or something which can be done so that the results are reproducible. Again, thank Dr. Maron and all the speakers for the wonderful lecture. And we'll meet up again tomorrow. It's rather late here. Thank you once again for the remarkable contribution that each and every one of you have made. I'm truly grateful for the wonderful contribution. Thank you so much.